Yes, great. Okay. So this is the Demystifying NHS Finance study morning. My name's AK Maheswaran. I'm a consultant anaesthetist in Leicester, and I'm the clinical lead for the one MA, which is all one thing. A lot of information and a lot more resources are available at the financeforclinicians.co.uk. It's not just for clinicians, it's just a shorter version of clinicians and managers and non-finance people. So there's a lot of PowerPoint presentations, a lot of animations, and links to all kinds of stuff that you might find useful on on that website. So the purpose of today is to help you understand and navigate the healthcare system with a primary focus on how the money flows and how that's all relevant. It's to give you tools and language to be able to make sure that you can navigate and improve the quality of the care you deliver. It is not about penny pinching. It's not about trying to be efficient, though that helps. And it's not about, always thinking about the money. It is about how you can use the financial resources that are within the system to deliver the best quality of care that we can to our patients. So we should always be clinically driven, but we do need to be financially aware. And that's the catch line. It's the motto, what we're trying to prove, what we're trying to kind of show. We want people to be clinical driven because that will always be the focus, but we have to be financially aware. In a system with finite resources, if we can save money in one area, we can spend it to improve another. And that's it. That's how it works. So the first thing I'm going to touch on is, and this is going to be something that underpins everything else that we're going to talk about later on this afternoon and today, is about value in healthcare. There are different types of value in healthcare, and it's something that's a term that's bandied about a lot. And so the different types there's something called allocative value, and that's to do with how resources are allocated. Now that can be at NHS England national level, it can be at ICB level, ICS level, it can be within the hospital or your organisation. And that's also called economic value. For most of us, that's not within our remit. For most people, what we talk about value, we talk about technical value, and that's how we make best of the resources that we have been given. And it's also called efficient value. And the last type of value is called personalized value. And that's understanding that it's slightly different. It's understanding that you and me may have different values. We may have different values to our patients. And to illustrate this, Virginia Mason Institute are very good, big on value in healthcare. And they worked with a health board in Wales, and they looked at introducing value-based healthcare into their system. And one of the experiments they did, or one of the studies they did, was to ask patients and clinicians in a neurology clinic about what they wanted out of their care, at their appointment. And the clinicians were talking about, preventing disease progression. They were talking about treating the disease, whereas the patients were much more focused on having more energy, getting better sleep, feeling less tired. Now, in some cases, and in most cases, they will overlap. The aims will overlap, but there will be situations where one will be different to the other. So it's just an appreciation of the fact that values differ, and that's called effective value. So if we talk about value as an equation, now, if you had to have one word, I'm going to try and make this interactive, otherwise it gets really dull. If you had one word for the top line and one word for the bottom line for technical value, so how we make best use of the resources that you have, using the chat, because I can't see hands, what do you think should be on the top line? What should be on the bottom line? So one word on the top line, one word on the bottom line. Outcomes versus cost. Okay. Okay. So you're right with the cost. Cost is the bottom line. Somebody has got the top line. It's quality. There you go. So quality over cost. There we go. Okay, so people have got it now. So there are three domains of quality. Now, this is an NHS England idea. So outcomes is right in some ways, because if you look at traditional ways of measuring value, they've often used outcomes over cost. Increasingly, we have shifted to using quality because it's more encompassing. And within quality, you get those three domains. Now, I think people have actually touched on all three of those in their so far, so I won't ask you to do it again. So you have outcomes in there. Now, when you're looking at this, it is about outcomes that may not be easy to measure. You have to pick the right outcome. There's no one outcome or outcome measure that fits into this equation. It is whatever outcome measure that fits whatever you're measuring. Now, that's where things get a bit more complicated, because sometimes it's not the easy to measure outcomes that are important. It may be something completely different. And over what timescale are we talking about? And a lot of and I'll talk to you why the equation is important in a second. But for an example, and I apologize, a lot of these examples are from my experience, so they tend to be secondary care based, and they tend to be anaesthetic or surgical based. But just to give you an idea, one of my surgical colleagues used a particular way of closing they've done a new way of closing an abdomen. So they make a big cut in the abdomen and they do a slightly different way of closing it. And it takes about half an hour extra to do that. So it reduces efficiency potentially, but it doesn't affect your length of stay. It doesn't affect your 30-day mortality. It doesn't affect anything in the first 6 months. What it does do is reduce the rate of incisional hernia. So when that wound breaks down a little bit and you get a hernia through that, it reduces the rate of that significantly. But you may not notice that, and you can't do that until you looked at the data for over 5-10 years. But after 5-10 years, it is a massive cost to the NHS, the rate of incisional hernias. So by adding half an hour on, if you were to use traditional metrics, you wouldn't identify any benefit. But by looking at choosing the right thing to look at, so over a 5-year period, readmission rates and incisional hernia rates, they can then show benefit. So it's important to pick the right metric for what you're looking at and over the right scale at a period of time. And patient experience is important, and patient safety is the other thing that is really important in terms of defining quality. So there are the three domains of qualities. For you may be asked at interviews, what is quality? According to NHS England, they are the three domains of quality, and three components make it up. And if you look at your quality commitment, quality strategy, which most organizations have, they will have something in each of those areas. So cost is divided into two components. There's your revenue costs, which are your day-to-day expenditures, for costs, which are big upfront payments. Okay, and most budgets in the NHS are divided into those two components. So the next little bit I've got to do is to talk about the NHS structure, a little about how money flows through it, and about the payment systems that are being used at the moment. So NHS since 1948 till this year has had multiple kind of restructuring, have multiple different plans and things like that it's evolved over a period of time. Important to note that even in its first year, it overspent money. So things haven't really changed massively. In 1962, there was Enoch Powell's hospital plan, which was to build a district general hospital for every 125,000 people in a population. Because hospitals originally in the NHS weren't planned, it wasn't or an organised system. It tended to be hospitals originated where there were in densely populated areas, so in the cities. But as the population grew, in 1962, they decided that they probably need to have a bit more structure. And they started doing it, but they ran out of money. In 1974, you had the introduction of the health authorities. In 1990, you had the introduction of the internal market, where organizations, and within the organizations, there was people competing. So competition was introduced in 1990 for organizations to compete with other organizations for care. In 2000, there was the NHS plan, and until recently, the biggest reforms were the Health and Social Care Act of 2012, which were the Lansley reforms, which were wholesale restructuring of the NHS. And then most recently, last year, there was the Health and Care Act, which tidied up things. And I'll talk about that in a little bit. So in the UK or England, and we're going to talk primarily about England. So healthcare is a devolved service. So what we're going to be talking about is primarily about healthcare and the NHS in England. Scotland, Wales, Northern Ireland have their own systems that are slightly different and far less complicated, really. But the amount of money that NHS gets is determined by Parliament and the Chancellor Exchequer. You'll get more details of this in a second, a little animation. But broadly speaking, the majority of the money that the NHS gets goes to NHS England. Slightly out of date slide. So it's just NHS England now rather than NHS England Improvement, with a small amount being kept by Department of Health and Social Care. The capital D, the DEL is the departmental expenditure limits. So that means that that's the cap on how much you can spend that's set by the Treasury. So you can see that the increases have been small. There was a big increase in 22 to 22, 23, but that was primarily related to COVID funding, and subsequent fundings have been much smaller funding increases. And in general, the Department of Health and Social Care funding, if anything, is going to go down rather than go up. So the Department of Health and Social Care has to fund about 12 to 13 different bodies. NHS England is one of them. How many others can we name? You'll have heard of most of these, or hopefully all of them. So in the chat, see if you can name the other. Well, let's even get 10 at least. So how many bodies can we name? Arm's length bodies. Yep, so you've got the UK Health Security Agency, formerly Public Health England. NHS Business Service Authority, yes. You've got that. GMMH, I'm not sure what GMMH is. HE, you would have been right with HE until about a couple of months ago. So HE no longer exists as a separate body. It is part of NHS England now. And its functions are being delivered out the regional teams. Yes, the Health Services Safety Investigations Bureau is one of them. So NHSX was never a separate body. It was a collaboration between the Department of Health and Social Care, NHS Digital, and NHS England. And so it was just a program rather than a body. And even NHS Digital, which was one of them, no longer exists. So that went in February. So a lot of those NHS Digital and Health Education England have been amalgamated into NHS England. Any others? Can you see all of the? Can you see this? Can you see the slideshow, or can you see the actual screen? That's probably the question I have to ask. Because if you can see all the answers, that kind of defeats the point. The actual screen. Okay. That defeats the point of me asking the questions. Oh, oh, how foolish. Stop scaring. Yes, I've got a hand up. Did somebody want to ask a question? No? We can do it again. Pretend. Yeah, we can. Let me see if I can get this working. Please sound. Right, I'll go through it now and we can pretend we've not seen all the answers already, and you can see my slides come up. So you've got the Medical and Healthcare Products Regulatory Agency. So they're the ones that are responsible for approving things like the vaccines, your devices, and other medicines that are coming onto the market. You have public, like I said earlier, UK Health Security Agency, formerly Public Health England. You have NHS Blood and Transplant, the NHS Business Services Authority, NHS Resolution, which is the legal, they patient safety and legal aspect of it. So they operate the indemnity scheme for trusts, NHS organisations, and you've got the Counter Fraud Authority. And then you've got NHS England, which is the commissioners. You've got NICE, the National Institute of Health and Care Excellence. Health Education England, NHS Digital do not exist anymore. And you've got a load of regulators. So you've got the Care Quality Commission, Human Fertilisation and Embryology Authority, the Human Tissue Authority, the Health Research Authority, and the new one that's come just recently is the Health Services Safety Investigations Body. Now, some of these bodies, like the MHRA and the UK Health Security Agency and some of NHS Blood and Transplant, have national, UK-wide responsibilities. A lot of them are primarily England-based, so they only cover England. Things like NICE are only English based. One of the reasons why the Health Education England was absorbed into NHS England was that when the government says they're protecting the budget of the NHS, they are protecting NHS England's budget, not the Department of Health, Social and Care's budget. So what has happened over definitely pre-COVID was that whenever they protected the NHS England's budget, they cut the Department of Health Social Care's budget, which meant that HEE, the CQC, NICE, all these other bodies had decreases, reductions in funding, whilst NHS England's funding was protected. So by absorbing Health Education England into NHS England, one of the ideas, it's not the main driver, but one of the things was to try and protect budgets. Okay. I'm hoping you'll be able to hear this. If you can't, let me know. Something to do with my settings sometimes causes issues. So this is an animation that kind of says all of this in a much more succinct manner, and talks about how the money actually flows through the NHS. It's available on YouTube if you just look up NHS Finance Explained. Can you hear anything? Because I can't hear anything.
No, we can't, sorry.
Which is pretty weird.
When you're sharing your slides, I think you'll need to select
No,
share with
I can't hear
computer
anything.
audio.
I can't hear anything you're saying. Have a look. You can't hear?
No, sorry.
Okay. Let's try this again.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. To create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have four main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
Okay, so we'll talk about the Health and Care Act 2022. So it was based on on something that NHS England put forward way back in December 2019, pre-COVID. And what was happening was that since the Health and Care Act in Health and Social Care Act in 2012, things had changed. And the NHS was working within, manoeuvring itself to work within a framework, the legal framework. And the idea was this would be mostly a tidy up and a shift towards collaboration rather than competition for the first time in probably 30 years. So obviously everything was delayed by the pandemic, and finally a white paper was released in February 2021 by the government, which had most of that stuff, but a few extra things, and received royal assent in April 2022 and came into effect in July 2022. Now, some of those things that that were talked about or came about and part of the Health and Care Act took a while to implement. And so some of the changes, like the merging of Health Education England and NHS Digital, have been delayed till this year. But primarily, it created the Integrated Care Board and the Integrated Health and Care Partnerships. The animation showed you what they kind of what they're about and what their roles are. But the key things that happened were it took away that duty to compete. So you can put things out for the ICBs and ICSs can put out services for tender if they wish, but they're not obliged to like they were previously. So previously, every single service had to be put out to tender. Now there's not, that obligation is not there. There is a duty to collaborate, so they are expected to work together, and you are allowed joint appointments and committees, which you weren't officially allowed. There were some joint appointments committees that occurred, but it was very much a complicated arrangement. The other thing that it did was to tidy up some of the structures. So officially, pre the 2022 Act, there were three bodies. There was NHS England, who is the commissioner, and then the regulators were the Trust Development Authority and Monitor. So way back when we were kind of trying to make things into foundation trusts, the Trust Development Authority was the organisation that was pushing to develop trusts into foundation trusts, and Monitor was the regulator of the foundation trusts. And when they decided that actually foundation trusts weren't all that, they decided to merge those two together, and that became NHS Improvement. And then later on, they realised that actually NHS England was saying one thing and NHS Improvement was saying another, and all the organisations were getting mixed messages, and so they decided to work together. And so for a period of time, they were called NHS England and NHS Improvement, but now finally tidied things up, and it's now just NHS England. So there's one body that oversees the whole of NHS in England. So again, a lot of tidying up. The thing that NHS England didn't ask for, but the government had decided to put in, was increased power to the Secretary of State for Health and Social Care. And so it is less of an arm's length body and less independent than it was previously. So the Secretary of State for Health and Social Care has more oversight than they did previously. Okay. Any questions on the NHS structure bits?
Yeah, just a quick question from me. Sorry, oh, my camera's there, but my screen's there. That's odd. Sorry, I'll talk to you this way. Yeah, just a quick question about ICB. Obviously, looking at the video, I'm just trying to jot notes down. What sort of decisions do they actually make for us as NHS England? Because I see that they have like the different bodies, but it's just confusing to see how they tie into us. Only because I liaise with them quite a lot, so it'd be really good to understand what they're actually doing for us. Thank you.
So ICBs are doing essentially what the CCGs were doing. Yeah, so that they're basically a replacement for the CCGs. So that's their main role. Increasingly, they'll be taking on responsibility from NHS England for specialised commissioning. So you have the NHS England regional teams, and they've delegated, so given some of those commissioning roles to the ICBs. And the exact how it's exactly structured will vary between areas. And it may be something that if you join the integrated care session later on this afternoon, they might give you a bit more information about the actual interactions, because it will vary a lot. Is there anything specific you want to ask about that?
No, not particularly. I think, yeah, it's just getting my head around it really. But if there's another kind of section on it later, that'd be really useful.
Yeah. So there's the next the session after mine is about commissioning itself. So talk to you about the ins and outs of commissioning, how it's changing, and then there's representatives from the ICB and ICSs for the Manchester one, but who would be able to maybe answer how exactly they're working together. And as I said, it will vary between areas.
Lovely, thank you.
Okay. Any other questions about the structure? Oh, okay. So NHS payment systems. Now, this is an area that's more complicated than it probably needs to be, but it is complicated. The NHS payment system has changed multiple times over the last 5-10 years. But how I tend to look at it is we break it down into the building blocks. So there are certain ways of paying for services that are used across the world. Okay, so there are 7 different components which every payment system in the world put together in different combinations. Some only use one, some use a combination. Okay. So if you understand the different components, it's far easier to understand how they're put together. So the first one is a block payment. So a block payment is a lump sum to cover a specific range of services, and a true block payment is one where it doesn't matter on the quantity that's supplied or the demand that's come up. Okay, and it's traditionally used for things when for services where things are difficult to measure, like community services. It's difficult to kind of quantify the amount of activity that the service is doing. So for those services, a block payment tends to be the way forward. The benefits of block payment is it's predictable. You know how much money as a provider you're getting. The commissioners know how much money they're spending. So that is the main benefit of a block payment. Now, intermittently over the last 5-10 years, block payments have been used by acute trusts, and obviously over the pandemic period, everybody was on block payments because it gave a bit of stability and predictability. So the problem with block payments is it is no dependency on the quantity of demand or supply. So you can deliver as little or as much as you want. If you do more work than you're paid for or than you predicted, then you don't get any extra money. If you do less work than you predicted, then the commissioners lose out. They don't get the value that they want. Okay, so it has pros and cons. Capitation is increasingly how we're shifting in terms of population health. So it's a lump sum payment linked to the size and complexity of the population served by a provider. So one of the main source of income for most GP services is this capitation model. It is also how ICSs have their funding model worked out, and also how a lot of the health boards in the devolved nations have their budgets worked out. And so what you do is you take your size of the population you're looking after, and then you factor in you adjust that population based on complexity. And that can be age, it can be socioeconomics, it can be market forces. There's lots of things that you can factor in, and that's where the controversy comes in, is how much you weight different aspects to adjust that population. So yeah, the capitation itself is a very established and well-regarded model. It is always the weighting and how things are weighted that's always a bit more controversial. Pathway of care, about 10 years ago, was thought to be a really important and a ideal solution to payment systems. And it was a way where you had a lead provider that would take responsibility of the whole pathway. And they could then subcontract essentially part of the pathway out to different other organisations. It was used in hospital maternity services, and so it was divided into antenatal, intrapartum, so during the birth bit, and then a postnatal bit. And you got one payment for each section, and there were different levels. So you had a kind of 3 levels for antenatal, simple, medium, complex patients. You had 5 for intrapartum, and then you had another 2 or 3 for postnatal. And the main problem with it was the good thing was that you could subcontract out different parts of the pathway. The main problem is that once you were paid, so for example, if you were deemed low risk antenatally, you got the pathway you got a low risk payment. But if you became higher risk during that period, you didn't get any more money. So you had multiple scans, multiple interventions, but you didn't get any more money until that you changed to intrapartum, and then you moved up or down the scale accordingly. So it wasn't really working in hospital maternity services. It has been mooted in the past for things like joint replacements, so from referral to the kind of workup, assessment, evaluation, operation, rehabilitation, all that could be put into a pathway, and that was thought of, but was never actually followed through. Pay performance is a key part of a lot of all contracts in the NHS, all which ways through. And pay performance is for things like for GPs, it's the quality for outcomes framework, the QoF payments, which can be up to 20% of your income. And then the sequins, which are the commissioning for quality and innovation, is what's used in acute community mental health services. It used to be worth 2.5% of your contract value. Now it's been reduced to 1.25%. And you get national and local sequins that are used to try and encourage organisations to develop better care. The problem with them was mainly the fact that they kept changing. So the sequins, you'd have 1 year, and then you'd have them a different one the next year, but you'd have the ongoing costs for delivering the sequin from 1 year to the next without the payment. And in many cases, the budgets would include sequin achievement as established, and you'd base your costs based on establishing the sequins or achieving the sequins. And then so if you didn't achieve the sequin, then you almost have a kind of reduction, and it was causing problems. So that's why they've kind of reduced the value. They're still important parts, but other drivers to improve quality, like enhanced tariffs and things like that, of best practice tariffs, which I'll talk about in a second, have kind of superseded them in general. Per diem is a lump sum payment per patient per day. It's not used very much in the NHS, but it is used a lot in Europe and other parts of the world. Probably the most well-known and increasingly used payment system is the case-based or activity-based system. It has various names over the years. It was called payment by results. It's changed to national tariff-based payments, and that's basically where you get a payment based on the diagnosis, treatment, and patient characteristics. So what would happen is you have your patient journey gets coded. You have the diagnoses based on ICD-10. You get your procedures or any procedures they had under another system, OPCS classification, and you have your comorbidities, and they put it into a little software program, and it comes up with a healthcare resource group. And they'll talk more about that in the coding session this afternoon, but that's what tariffs are essentially linked to, these healthcare resource groups. They work very well for elective work, because generally elective work, the costs are less than the tariff payment, roughly. And when they came in, they were designed to bring down waiting lists, and they worked very well in bringing down waiting lists. They don't work very well for acute care, for emergency care, acute emergency care. So, and that's mainly because they cost a lot more than to deliver than the tariffs were, essentially. So it is very good for driving down waiting lists, because it gives you an incentive. But it's not always. But that's only works if you make money on each case, rather than, or at least break even on each case, rather than losing money on each case, which was happening previously. Then you had pass-through payments, which are cost of services delivery paid by the commissioning body directly. So you say how much it costs to deliver that service, and the commissioning body will pay you directly. And that's things like high-cost chemotherapy drugs, some of the really niche specialized services that have to be provided are paid for in that way. So having decided that there are the different components, you have the current system. Now, this is the current system for the next couple of years. Yes, Suisha.
Hi, a quick question. Who decides what kind of payment the trust gets?
NHS England.
Okay.
So this is I'm going to move on to this next slide, which is the current system. So for the next 2 years, your payment system for majority of your services will be based on this aligned payment and incentive program system. And so it excludes low value activity contracts, which are less than £500,000, but all the others are based on this system. And what it essentially includes is this fixed element, where you get an agreed level of acute activity or maternity, mental health, community and ambulance services. includes your CNAC contributions, expected best practice tariffs, and sequin achievement, and all that kind of stuff gets put into this fixed element. So that's kind of a block bit. So it's a block contract component to it. And then you get this another bit, which is an elective variable element. So that's an activity-based component. So this is where the more activity you do in the elective sector, the more money you get. And that's elective, ordinary, and day case. Outpatient procedures that have and the NHS SPS is the NHS payment system unit price. So there's a big document that has all these payment system unit prices. You get the more outpatient first attendance you see, the more money you get, more diagnostic imaging and nuclear medicine and chemotherapy delivery that you deliver, you get more money. So that's activity based. Okay, so that's one element of the variable. And then you get another element of the variable component, which is if you basically gets deducted a small amount if you don't achieve your best practice tariffs or your sequins. Okay, so I would say that the majority, if not all, organizations are paid on this system. Now, there may be some exceptions where some specialized services will still get paid by a block component, or they will get paid by a this pass-through system. So I know in our hospital, ECMO gets paid extracorporeal membrane oxygenation service gets paid via block for X number of patients, which is commissioned by NHS England. So this is the system that is being used at the moment, and it's going to be used the following year as well. So they've decided that this payment system will work for 2 years, and they may change it after that. Does that make sense?
Yeah.
Yes. I couldn't see who the name was, but there was a hand up. Yeah.
I'm Abby.
Hi,
So I
Abby.
just wanted to ask a question. So does it mean that when a trust is on block payment, like what you said with the ECMO, does
Yeah.
that mean that all the services within that trust will be on block payment,
No,
or can they still use different types?
Yeah, so it's that component. So that service. So with all these things, so when they say agreed level acute activity, they'll break it down into different bits. So there'll be the acute activity 100. You put forward how much it's going to cost you for the fixed element bit. It'll be you put forward how much activity you've been performed in the last year. So it's a negotiation over a period of time. So normally it starts in the September. So contracts run from April to April. Things starting to work in kind of October, November the previous year, where the trust gets the data of the activity they've done and or starts getting that data, and the kind of discussions start working of how much it's cost to deliver that data, that level of activity, which you then take to the commissioners and go, look, this is how much it's going to cost to deliver this activity. This is how much we think it's going to increase. This is how much money we need to deliver our acute activity, maternity, mental health, and community ambulance services. Okay. And so that's how that block component is discussed for the kind of this fixed element. And then you obviously have the variable element, which it's topped up based on how much work you're doing. So it's for different services. So it's all a combination, which is why I said these are different building blocks and different components are put together. Does that make sense, Abby?
Yes, thank you.
Okay. That's my first bit done. If you have any other questions, feel free to ask. You can email me at ek@clinical.finance. Anything more specific, or you can contact the One NHS Finance team, and they'll forward it on to me. Any other questions on that? No. So either it makes complete sense or it's completely mind-boggled everybody. So I'm hoping Patrick is on the call, because I think I finished on time.
You were very close, AK, very close. I can't criticise that. But we'll be very clear that my bit will boggle minds rather than being transparently clear.
Great. So I'd like to welcome Patrick McGinley, who is head of costing and SLR, service line reporting at Mason, Tunbridge Wells NHS Trust. Is that right? Is that still right?
That's absolutely right, AK.
I don't often get the titles right, so I'm pleased. That's only because I worked with you before. So he will give you a thorough update on how commissioning is working and changing over the next few months. And I'll be back after screen break to talk about business cases. Over to you, Patrick.
Thank you very much. I'm just checking whether Becky's going to drive the slides, which would be helpful, but
I can do. Let me get them up.
lovely. That might be easier because I've had slightly flaky Wi-Fi this morning.
Give me one sec.
So just to fill in the dead air, which of course panics every presenter ever. Hopefully this session will just build on some of those important points that AK was discussing at the end of his presentation, and that I think had inspired a few of the questions about how the decisions are made and what the implications are of a particular funding system. As AK said, I'm the head of costing and SLR at Maidstone and Tunbridge Wells NHS Trust. So we are in the, hopefully, as you will see, the desert of financial settlement. And that's why it's always much more difficult for us than it is for colleagues in the north. Of course, being from Kent and Medway, Southeast London counts as in the north to us. So if we pass on to the next slide, we'll start with, I think, a definition of what is commissioning. And this really does build on that last point that AK was making about it being it never really was a process that was a one-off, and I think that's a particular challenge of the fixed element of the aligned payments going forward. While accountants sit in our ivory towers hoping that we can make a payment system work and that we can deal purely with pounds and not have to do difficult things with patients, it's never fixed in any way, shape or form. Innovation, changing clinical practice, changing demographics, changing local boundaries, all have an impact with how commissioning is undertaken. But I think one of the real changes from the legal implementation of the integrated care boards from last June is that very definitely is a continual process now rather than a one-off where we get a contract signed by the 31st of March that's effective from the following day for the next 365 days. It may come as no surprise to anyone that never actually happened anyway. We signed last year's contract on the 31st of March of the year that it was current for. So that's how far behind we are. But the commissioning needs to be seen in that sense of how do we make those changes? How do we implement better clinical pathways for patients? How do we look to build a synergy of healthcare that is about putting the patient at the centre? I think, as you will all have seen, many of the systems that are set up are almost deliberately aimed at not putting the patient at the centre. And I think commissioning is one of its central roles is to bring that focus that it's not about financial transactions. It is about how we are providing healthcare for people and whether that's the most appropriate healthcare, is it in the most appropriate place, and is it providing the best value, become some of the things that need to be considered. And that does mean within the sort of new world of integrated care systems and integrated care partnerships that we need to be looking at how we are looking at the whole population and not be quite as focused on, have I got a good deal for Maidstone and Tunbridge Wells? Does that mean that it's a bad settlement for East Kent? Or does it mean that we can all laugh at the ambulance trust's plans for new ambulances? Commissioning now is much more integrated. How can we actually benefit everybody within the population? So if we have the next slide, please, Becky, thank you. This, I think, may help focus some of the
Sorry to
discussion
interrupt,
points.
Patrick. We can't see the slides anymore. It's come off our screens.
Oh, well,
I don't know if you can see the chat, so I thought I'll just say it.
I couldn't. Oh, I don't know if Becky's got a good settlement. Have we got any change?
Yeah, we can see that now. Thank you.
Does that work?
Yeah, that's on our screens now.
Okay. Let's see. We go from there. I think there was a question earlier on about who decides what form of contracting and commissioning there is. AK rightly said that it's set by NHS England, and this slide kind of reinforces how the money flows through the whole system, and reinforces the point that's just been made about the ICB holds the money and it allocates it to all of the contractual partners through a process of subsidiarity, but it's the ICB that are responsible for the delivery now, which is a very new concept. I feel still slightly strange that I have a budget for the year. That's good. Accountants like a budget, but actually, I'm not totally responsible for it. And if it fails, then I can go to one of my golfing partners and say, I'm sorry, I let you down. I suspect in the real world that it won't happen that way, but it is the ICB that holds that budget from NHS England, and looking to develop integrated care partnerships. I think it's fair to say that they have not developed as quickly as the original guidance was looking for, but is finding a way of linking primary care networks, practices, provider collaboratives and NHS trusts into some place-based partnerships that will allow for better healthcare to be commissioned by the partnerships under the ICB. As AK was saying, and just reinforcing in terms of what it means for the change, that the ICBs that they start from different baselines. I'll come back to that. There's some. I say some. The largest element is the mainstream commissioning that they picked up from CCGs before them. There's a separate weighted capitation funding for primary care, and a third separate capitation funding system for specialised services, and they're all brought together in different ways with different weightings, as AK was saying earlier on. It's important to remember that ICBs haven't started with a completely clean slate, so many of the commissioning decisions are influenced, is the kindest way of putting it, by the inherited financial position and the inherited activity positions and inherited contractual arrangements. And those baselines and trends that produce those positions are also what the ICBs have picked up. And a number of implications come out of this. The graphic on the right here shows the CCG funding per registered patient in 1920. 1920 is one of those desperate years that accountants in particular like to grasp at because it was the last year of normal. That in, of course, in itself is a fib because, as AK was saying, a lot of trusts and CCGs were in a relationship at that point where the funded elective activity and the unfunded non-elective activity was greater than the funding available, and therefore we had started to increase waiting lists and waiting times in 1920, and in fact we probably started doing that from 1718 onwards. It just became more and more transparently clear. The darker the colour, the higher the funding per head. So it's good if you live in the northwest, the northeast, North Norfolk. I wouldn't put Cornwall quite there yet because they've got higher funding per patient, but their costs are horrendously high. Middle England, much less funding per head, and that affects what we can do through commissioning with the outcomes that we want to deliver. The emerging commissioning for 23-24, because I think that the point that AK made that was absolutely fundamental is that this is a 2-year process, and therefore it is still emerging in year 1. And I have a horrible feeling that quite a lot of us are putting in big assumptions for recovery in year 2. But the important headlines, I think, are that specialised commissioning policy has been confirmed, that there will be a transfer from NHS England as commissioner to the ICBs as commissioner. It will be a staged process. There was a number of contradictory policy iterations throughout 2022 about whether it would go, wouldn't go, would go, wouldn't go. It started to go. There's an outline of which services are deemed to be in place now and which will be ready by next year. The aim is that at the end, NHSE will retain a small, important commissioning role, but it will be for the ultra specialised services, the areas where individual patient injections can cost up to £1 million, but there'll only be 3 of them in the year, that sort of thing. It's probably important to remember that specialist commissioning is essentially an insurance scheme, that we don't have exactly 1.1 billion available for chemotherapy and 800 million available for radiotherapy and other sums available for cardiac devices. But if you put them all together, then if we slightly overspend on chemotherapy and slightly underspend on radiotherapy, it balances out. By delegating that commissioning responsibility to the ICBs, we've gone from 1 central insurance scheme to 42 insurance schemes, and it is to be hoped that we've picked exactly the right numbers and delegated exactly the right amounts. I'm just off to the bookies now to place a bet that that may not be quite right. We have been bombarded locally with colleagues from pharma industry saying, is it still a pass-through for high-cost drugs and chemotherapy, and is the Better Care Fund still available, and all sorts of questions like that, where they're focusing on will there be any pressures on reducing the volume and spend on high-cost medicines, and we're having to give the news that although it's still a pass-through, and inertia will mean that it will remain a pass-through for some months at the very least, and possibly years, there will be a change. That insurance scheme now runs into how can we invest in better primary care? How can we invest in better mental health? How can we invest in better community health services? If you've got a small underspending on your radiotherapy fractions budget, that is likely to be swiped. In fact, it's a legal requirement that the ICBs swipe it. So there's much to change there. In terms of specialist commissioning, there will be 3 cohorts of services, those that are available, those that will transfer, and those that won't ever transfer. There are 9 joint committees set up in order to manage those specialised services within the 42 ICBs. I think 9's an interesting number. Would I be surprised in 2 years' time that we were down to 9 integrated care boards? No, I would not be surprised if we were down to 9, but that's a personal view. Just reinforcing some of the points I've made at the moment, high cost drugs and devices are staying national, so does the Cancer Fund. there are national specifications and commitments to implement NICE guidance. There is no money for that. There is never any money for implementing NICE guidance. You have to do it, but we have no money for it. As ever, the devil of what it really means for a particular service in a particular ICB is in the detail, and there is an amazing amount of detail that is still absent. But if we look at some of the points I made earlier about the commissioning funds, these are some of the regions of England and their allocation, what it means per head. And this was my point earlier on about the ICBs having 3 pots with 3 different weighted capitations. I put in there that on the right hand side, you can see, for instance, that North East and North Cumbria, they're below a national mean per head. But they're above from that earlier map graphic from the general commissioning. The southeast was below from general commissioning. It's very marginally below in specialised commissioning, which just means there is no money in the southeast. These are the baselines. These are the budgets that we'll be working away from. And that means, I think, that the days of ring fencing, this is the budget for chemotherapy, or this is the budget for radiotherapy, or for ECMO, or for adult critical care or neonates, so that will start to become eroded, that ring fencing. The ICB will be in charge of the process environment, where we move money from chemotherapy, radiotherapy, high cost drugs and devices into frontline mental health services, community health services, or whatever. The commissioning framework will still need management, and there's an interesting, I think, potential wrinkle for commissioning. At the moment, the ICBs have the money, they have the power, they have the levers to make change, and that is all right and good. Providers are encouraged to work together as a provider collaborative. I think some of the more far-sighted collaboratives might become quite powerful in their own right. I think if you're District General Hospital in the middle of Kent, purely as a for instance, and you have a clinical relationship with inner city London teaching hospitals for the provision of specialised neurosurgery, bone marrow transplants, cardiac transplants, and haemophilia services, for instance. I think that becomes a provider collaborative. I think the teaching hospital gets to set the rules about how funding will work, how activity referrals will work, how referral of patient back to the local community will work. You know, I think if I was a London teaching hospital, I'd be very keen on patients post bone marrow transplant, for instance, being seen locally at a DGH in Maidstone or Tunbridge Wells or Ashford or Canterbury. And I will be in charge of delegating what proportion of the agreed finances for that follow-up is. So I think the provider collaboratives might become very important. I think there's a role for franchising. I think some of the specialist hospitals, Moorfields is an obvious one. They've got a very robust franchising model. I think Great Ormond Street and the Evelina might be 2 others that step into that. The Marsden may as well. Clatterbridge equally, of setting out what the relationship is if you want to benefit the most from working together. And this just reinforces the earlier points about the ICBs and how much per head they have. So these are the top 5: Cheshire, Lancashire, North East, North Cumbria, Cornwall, Great Manchester, much in line with that earlier map. Kate, I see a question.
Hi, sorry, it's just back to that previous slide. I was just thinking, you'd mentioned that the ICB are going to be responsible for moving the additional funding potentially for the HCD
Yes.
services. How is that possible if it's still overseen by the NHSE?
Yeah, certainly by the end of 2020, 24-25, it will be the legal responsibilities of the ICB.
Oh,
There's
okay.
a sort of stasis year this year where the 9 corporate groups come together and make sure that, you know, North Cumbria don't take all the money and disappear and say we're going to reinvest this in primary care networks or whatever. So there'll be a managed process this year, but it will be the ICB's responsibility next
Okay.
year. And they have a legal duty to break even this year, which NHS England don't. So actually that legal responsibility of balancing the budgets may give the ICBs a little more of a lever when they start saying, I know this money was for high cost devices, but we're underspent by 200 million there, and we're overspent in secondary acute care by 200 million. So we're going to move them. I suspect there won't be anything done in August or September of this year. I suspect next January, February, March, those sorts of decisions will become crystal. You know, people will start saying, well, you're not going to spend another 200 million in high cost drugs in the next month, so we can move it. And I think that becomes an interesting commissioning challenge of what priorities do you set? How early do you set them? Or are you just going to go, let's see what's underspent and nick that money, which doesn't seem to me entirely the best way of planning a health service, but maybe I'm missing a trick. But very good question. But equally, just to point out there that you know, if we look at the lowest funded ICBs, um, uh, Buckinghamshire, Frimley, Bedfordshire, all fall within the southeast. Leicester, gonna have to do the accounts, boys. And northwest London, there's a sort of north-south divide between the top 5 and the bottom 5. But actually, some of those percentage differences are really quite significant. You know, Buckingham, Oxfordshire, and Berks, 16% less per head of population than the average, and nearly £450 less than the highest ICB in the country. That's a big swing, and I think as ICBs get more settled and get into their second and third year of financial existence, at that point, then there's, you know, some real pressure comes on how do we increase the funding from the areas that are below the mean and therefore reduce the ones that are above, or increase overall funding, both of which are unlikely in the short term. And just for probity, Kent and Medway, 1526, we're just under the average of 100. You know, so yeah, we're suffering. I just put that one out earlier there. In terms of the points AK was making about the challenges for commissioning, these I think are some of them. I've just taken one here that I think we can look at particular disease areas. I've just picked up rheumatoid arthritis because I'm an accountant and I know nothing about it. So that's always the best way of instilling knowledge. And this goes back to some of the points that AK was making earlier about how the acute activity is recorded and coded and grouped into healthcare resource groups, and brings into sharp relief, I think, some of those challenges. I think that the reason for choosing rheumatoid arthritis is that I think we can all intuitively say, oh yes, we know what that service might look like. It, you know, who are the patients, what is the population health, how are they presenting, how are we treating them, and it does have that lovely interaction between primary care and secondary care, between acute and chronic episodes, and has the use of high cost medicines. So that's all the challenges in one single group. And the point here is that, you know, there's a nice technology assessment that came out in 2021 for the use of adalimumab. That's quite technical. I don't know that everybody talking about the commissioning of rheumatoid arthritis would necessarily know all of the technical terms and be au fait with whether intensive therapy with 2 or more conventional disease-modifying anti-rheumatic drugs was or wasn't being controlled, and how we define that, but we're going to commission it anyway. And it needs to be for patients where the disease is moderate, a disease activity score of 3.2 to 5.1. Well, what happens if it's 3.19? What happens if 5.16? These become the key commissioning arguments. But I think the reason for throwing this out is if we're looking at the information that we've got, that AK was talking earlier on about how we start the commissioning process and monitor the commissioning process and change the commissioning process. What we're very good at is having lots of detail on interactions, particularly in secondary care. So these are the rheumatology outpatient procedure costs from 2021, the most recent available, which again shows part of the problem, that if you're planning the services for 23, 24 and 24, 25, if your most recent costs for outpatient procedures are 2021, there's going to be several different assumptions on the rate of inflation, for instance, the impact of medical pay awards and other pay awards. But this highlights the challenge that AK mentioned. Here in 1920, the average cost for an outpatient procedure, and I chose outpatient procedures because that's where we should be recording injections of adalimumab. These are all charged to a local commissioner for the actual procedure. The costs should exclude the high cost medicine. The average cost was £323, and it had been slightly higher in 2019-20. They go to local commissioners. There is no way that a local commissioner is paying £323 per outpatient procedure. Probably somewhere about £187. That's that pressure that came onto secondary acute care that AK was saying meant that we got rid of payment by results as a payment method, because it is only sustainable if it's around about the average cost. So if you have to do 100 to cover your costs and then everyone after that makes a little surplus, we understand that. We'll try and do 130 in acute care. Commissioners will want to limit us to about 100 because that covers our costs. And we can talk about those figures, but each of those is a patient interaction. And what we're not good at is, was that 100 patients? Was it 50? Was it 25 who came 4 times a year? We don't know. And that becomes a real commissioning challenge. We're looking to reduce outpatient follow-up activity by 25%. That's one of the rules set out by NHS England that the ICBs have to implement. And outpatient procedures rely on somebody recording the procedure, recording the injection, putting it into the patient record, and then coding it and grouping it, as AK was saying earlier on, and that you will hear about this afternoon. If we don't record the injection, it's just an outpatient follow-up. Now, the challenge is that no form of outpatients is coded by clinical coders. And they can be involved, and in good places are very actively involved in producing a drop-down list of which codes to use, but they're not clinically coded episodes in the same way that admitted patient care is. And even when we are recording the procedures well, there's nowhere on the outpatient procedure, outpatient clinical commissioning data set to put a diagnosis in. So these were outpatient procedures recorded under the care of a rheumatologist, but we don't know which diseases they were. We can't say that that is rheumatoid arthritis. It probably is, but we don't know. And that lack of knowledge, I think, that detail where we're very good at recording an attendance and what happened, we're less good at recording the patients and why we did it. In terms of the pathway, I've just flagged this one up. This is 2021 non-elective admissions where the primary diagnosis is rheumatoid arthritis, either seropositive or seronegative, other, unknown, or not classified. And again, I think there's a commissioning challenge where yeah, 3 of the 5 categories are other, unknown, or not classified. The average cost of those admissions is about £2,017, or was about £2,017 per admission. Each of those admissions will have had an A&E attendance prior to it, and we can't record diagnosis in A&E either. So we are moving the goalposts for commissioning without necessarily knowing what it is that the population health challenge is. Now, I am going to stop presenting there, and like AK, I am really hoping that that was just so clear and transparently obvious that there are no questions, but I'm very, very happy to take any that you have. And I've just seen some of the points in the chat, and absolutely, Nina, that is definitely one of the key challenges in managing the funding, that the lower funded areas may have low deprivation, but that demographic change of the older population is essential to this, and we haven't got that. You know, maybe we move towards a funding system that is, you know, babies, they take care of themselves, so, you know, what can we say, 50 quid a head, to, you know, middle-aged accountants should probably have about 2,500 per annum set aside for our healthcare needs, you know, and physician heal thyself. I think that's but there's a real point about how that funding, we can agree, as AK said earlier on, about the mechanism, how it's calculated, but actually what are the impacts? And, you know, the country's just not homogenous enough to make one funding system work for everyone. Are there any other questions? Otherwise, we might get an extra 2-minute break.
There's one more question. Why is the justification for higher funding per person in the Northwest? It was in the chat.
Because we love the Northwest, and we had to fund Devo Mank in some way. No, I think that is absolutely the key challenge, is that the ICBs have inherited the funding system that was already there, but that funding system runs back to 1974 and the Resource Allocation Working Party. Now, I'm not quite old enough to have been on the first RORP, but I was on the second one. And the difficulty is, how do you manage that change from saying, right, there is a difference between the levels of funding in the Northwest and Northeast compared to Central England and the Southeast. There isn't enough money just to go, right, we'll bring the Midlands and the Southeast up to the same levels. And there certainly isn't an easy facility to say, Manchester, you're overfunded, we need to take that money and give it to Birmingham. Because nobody in Manchester is going, I've got all this money and I don't know what to do with it. You know, it's being spent at the moment. If we change that, then we have to make those decisions about what we will stop doing in Manchester in order to start doing something better or more of it in Birmingham. I see a hand up, but I can't see whom.
Hi, a quick question. I'm Surisha. It's about diagnosis. I guess it's a two-part question. It isn't difficult to document a diagnosis and the outcome after an outpatient consultation, or that we are asked to. How is a diagnosis important in terms of funding or commissioning?
I think right. There's no difficulty in recording it. There's just no way of inputting it onto the clinical data set. There isn't a field for diagnosis in the data that we have to submit. The challenge for commissioning, of course, then is we can all be sure that, you know, if you're going to Dr. X's Thursday clinic in rheumatology, it is his rheumatoid arthritis clinic, but that isn't the same as saying every patient there has got rheumatoid arthritis. You know, I think particularly if you work in healthcare, you're absolutely aware that, you know, it's quite easy to go, you couldn't just see X at the end of the list, could you? And X may not be a patient with rheumatoid arthritis, but they may be available to be seen in a mutually beneficial way. And I think the challenge, therefore, then is if we see the secondary acute position of treating rheumatoid arthritis, but we don't record the disease and we don't record the diagnosis, it then becomes difficult to say this is what we're spending the money on. You
Okay.
know,
Yeah, that makes sense. Yeah.
and that becomes a challenge. You know, and I think it's quite fundamental. You know, we don't know why you're in this patient in this particular clinic. You know, we've badged the clinic administratively as rheumatoid arthritis or glaucoma or strabismus or whatever. But that doesn't mean there's no other indicator that says everybody here has got glaucoma.
Yeah.
It might just be, well, you know, 12 of the patients do, but 2 don't. But they
Yeah.
could only make Wednesday afternoon, so they're here. And that, I think, is the challenge then for how we look at pathways. If we've got elements of the pathway that we don't record the diagnosis in,
Yeah.
you know, are we sure? Yeah. And you know, and then especially with you know, how we look at comorbidities, you know, are we running particular clinics, are we dedicating particular resource for patients who have this and that, and we don't record either this or that, you know. It's kind of hard to say that we're commissioning in the best way if we have huge areas where we don't record a diagnosis, in my opinion.
No, it makes perfect sense. Thank you.
Pleasure. If there's no more, I think I've delivered on my time. Just about.
There is one slight question. We will extend the break to make sure that people don't lose out. But so what happens? It is about treatment in out of areas, I think, essentially.
Oh,
right. Say on holiday, and you're treating one area.
That would come under the point that AK highlighted about the low value contracts. You know, that if you go down to Cornwall and you from Tunbridge Wells and you disappearing down some of those vertiginous villages that do insist on the side of cliffs and break your ankle, that will come under a low value contract, that there will be a transfer based on past history of the number of people going from Tunbridge Wells or Mid Kent to Cornwall and falling over and fracturing something. If there is an increase and it goes above the £500,000 threshold, then there'll be a discussion to be had about why you're sending so many accountants down to Cornwall. They're costing us a fortune down here. But if it's, you know, in line with previous years and is low value based on holidays, then that will be covered under that low value contract of below £500,000 as a block.
Thank you very much, Patrick.
No problem.
So we will have a screen break for 10 minutes. So it's my session next, so I will start back at a bizarre time of 12 minutes past 11, which doesn't quite sit my OCD, but there you go. In the meantime, so feel free to go and have a stand up, a coffee, whatever else you need. There will be some slides on here that one of our partner messages from our partner organizations that will go in the background every so often about other learning opportunities that the HFMA can provide. And before we come back and before I start the business cases session, I will be talking about the NHS Efficiency Exchange, if I can say the word, which is a new initiative to try and share ideas amongst organisations. So I will see you back in 10 minutes. Enjoy a coffee break, There will be some slides in the background here if you wish to look at them. Hello and welcome back. Hopefully you've had a bit of a stretch and a walk around and are feeling reinvigorated to talk about business cases. I did mention I was going to talk about something about the NHS Efficiency Exchange, which is just a platform that enables NHS organisations to share free-form efficiency ideas and projects at local, regional and national level. It's a collaboration with NHS Trusts via the National Efficiency Forum, first established in March 2022. They want participation in the exchange from all areas of the NHS, including clinicians, finance and operations, as multidisciplinary collaboration is essential to improving our NHS. Ideas can relate to cost reduction, productivity, and cash/non-cash releasing outcomes. The platform aims to facilitate the implementation of replicable projects. So essentially just sharing. You can access the Efficiency Exchange via the One NHS Finance website. And if you couldn't tell, that was a blurb that I read out rather than something that I came up with. So talking about business cases, what are people's experiences of business cases? How many people have done business cases? Is there anything particular that people have struggled with, or is everybody very new to business cases? Because that is going to be an important factor in how I take this. I will start with, for most people, I will start with the basics, but if there are anything particular people want to talk about because they've had difficulties in the past, we can discuss it. The thing with business cases is that we're going to be talking about the generic structure. Every organization will have a different process. The business cases, they'll have a different form, they'll have different hierarchical structures. So what I'm going to be talking about is we're going to be covering everything from like the 2-page business case to the big business cases. They generally follow a similar pattern. And in order to kind of encompass everybody's different abilities, I'm going to use the 5-case model. It is what has been recommended for use in all public sector by the Treasury for the last 20-30 years. And it is the basis on which all business cases are assessed. So the idea is you take what I'm saying and you kind of take that information and you just have to put it into the forms that you have. That is the recommended model. That is increasingly what organizations are shifting to. And that's what we'll try and talk about. And I'll try and cover the pitfalls. I'll try and cover some of the issues that people have faced in the past. Okay, so I guess the first question I've got to ask, and it's really an open question, is what is a business case and what's it for? So what do you think a business case is, and what do you think the purpose of a business case is? And there are 2 answers to this. And then while you're thinking about that, what do you think needs to be in the business case? Because there are business cases and there are business cases. There are different ways of looking at it. Okay, so we've got different things. We've got what you want to do, what the risks and the resources, yes. Share a case for change and requirement for funds. So often you're putting in a request for resource. Now, that's the most common reason. Okay. The other option is that it's a description of the process you went through to come up with your idea. Okay. So it's a process evaluation as well. The main fundamental flaw that a lot of people have with business cases is they start with an answer. They start with what they think the answer should be. So this is a business case for a new service. We want to create this new service, and this is the business case for it. And that means you have very narrow-minded thinking, because you know your speciality, you know your specialist area, you know the ins and outs and all the problems and all the issues, and so you have in your mind what you have the answer is. So this is the answer. That's how it comes out. What somebody looking at the business case, evaluating the business case, probably doesn't have that breadth, the depth of knowledge that you do about the area. And when you're evaluating a problem, the multiple business cases, you want to know that there's a problem that is being addressed. So what is the problem being addressed? And that should be the basis of your business case. Because then you can start thinking a little bit naturally and think about all the different options and what the things that other people are going to think about when they're looking at a problem. So, you know, if you want to provide a new service, is it because the current service is not up to scratch? In which case you have to show the current service is not up to scratch. And then you have to think about all the ways you can resolve that. This new clinic might be the way forward, but there may be other options. And what you don't want people to do is keep coming back to saying, what about this? What about this? What about this? You ideally need to encompass that and have to say you've thought about that in your business case. Okay. As always, can't do a Teams meeting without some slides. So there's no sound in this one, unfortunately. There are little fancy graphics. Okay. So we talked about what business case is. The first thing you probably need to do is understand what the process your business case is going to have to go through. And in order to do that, you probably need a broad idea of how big a business case it needs to be. And identify what paperwork you need, and what hoops you need to jump through. So how many committees does it need to go through? Depending on the size of the business case, some can be done internally within your department, some have to go to your organisational board, some have to go to your commissioners, depending on the process. Okay. And then think about the budgets. Whose budget is it coming out of? Is it coming out of, which budget is the most suitable? Is it an education budget? Is it a kind of standard budget? Is it something else? So there are ways of looking at different ways of pots of money. This is a very generic slide, but basically it covers what needs to be in the business case. All the details: who, what, where, when, why, how. And what we're going to do is try and put this in a structure. We're going to put this into these kind of all these questions into structure so it makes sense. And yes, it is a pitch. It's like a Dragon's Den pitch, but on paper. And that's how you've got to think of it. Dragon's Den pitch on paper. You are pitching this to other people. So we're going to use the 5-case model. There are 5 cases to it. The strategic case, the economic case, the commercial case, the financial case, and the management case. I'm going to focus on the first two, the strategic case and the economic case first, because they are the most important. That's not to say the others aren't important, but for a lot of the others, you need specialist input. You need the commercial case, you'll need procurement, you might need HR. For the financial case, you'll need finance involved. Okay. So you're going to have to get, business cases aren't generally done by one person. They're done by, getting information from other people, particularly the bigger ones. I'm going to put those into context. Now, the aims of a business case is it has to be desirable. It has to be something you need. Okay, it has to be something that aligns with the organisation and what they're trying to achieve. It has to be viable. Okay, and it has to be achievable. So within a particular time frame, you've got to set the time frame. It has to be achievable within that time frame, and you have to kind of specify the time frame in your business case. Generally, the number one driver for a business case is solving a problem. Okay, you have to show that there's a problem that needs to be solved. That is the number one driver of a business case. there are occasions where you can use a business case to improve quality. Okay. In days gone by, when it was a true payment by results or national tariff type model, you could have a business case that would generate more income. But that doesn't really apply anymore. It's about improving quality, because the pot's finite. And so generating more income doesn't really work and doesn't carry the weight it used to have. So it's about improving quality and solving a problem. And you have to show it. We talked about the value equation before. Okay, so I'm going to put it back again. The purpose of this equation is twofold. When you have the guy, Michael Porter, he was a Harvard business professor. He basically said there's 2 points to it. One is that generally improving quality will reduce costs. Okay. The problem has always been that the costs may not be to your department, they may not be to your organization, they may not even be to your area. It might be societal benefit. Okay, it might be societal costs, it might be environmental costs, it might be other costs that you reduce. Okay, but when we're talking about value in healthcare in this context, we focus much more on capital and revenue costs. Okay. And so to achieve value, you have to show that there's an improvement in either or one or more clinical outcome, patient experience, patient safety, and it's worth the cost. Now, we could knock down every hospital in this country and probably build a new one, and it would probably improve the quality of care that we deliver. But it may not be worth the cost of doing so. So there's that you have to show that the benefit and the improvement in quality is worth the cost. Okay, so that. I'll bring this slide up in a bit, but this is basically the components of the business cases. I'm going to go into the flow of it. So if you have a bigger business case, the big bulky business cases, you divide it into 3 sections. Okay, you have your strategic outline case, you have your outline business case, and then you have your full business case. For the smaller business cases, you kind of go straight to your full business case, or maybe even jump a step. Okay. But for the big ones, it kind of goes up to a 3-stage process. And you develop the different parts of it in different stages, mainly so that you don't spend too much time on a case that's not gonna is a non-starter. So just going back to the strategic case, the key thing you've got to do here is show how your project, whatever you're asking for, fits into the organizational aims and ambitions. So whatever is in your organization's roadmap, your annual plan, whatever they call it, how does your business case fit into that? How is it going to help? The context, you've got to contextualize it. It's got to fit into that. Okay. The big red flags are a lot of processes, a lot of organizations have a checklist. And one of the key things, just a quick one at the beginning, and one of the key things you've got to do is it's not going to negatively impact any of the key performance indicators. Okay. So in my organization, will be things like the 2-week wait for cancer care, the 52-week wait, all those. If it's going to negatively impact any of those key performance indicators, they'll probably get dismissed straight off. Okay, unless you factor that in. Okay. I used to, pre-COVID, we used to run a few business case, what do you want to call them, workshops where you have a few people who would come on and pitch their business case, and we would go through them in detail, and I would poke holes in it, essentially. That would be my role. And so there was a radiologist that came on, and they talked about this new technique as part of the breast screening program, and it would involve putting a cannula in and injecting some sort of a different way of improving the quality of breast screening. And my key concern was that, yes, it's great, it'll reduce the number of issues, but if you then, obviously you do see fewer patients per session. So unless you increase the number of sessions you have, you're going to negatively affect the 2-week wait. You're going to potentially cause holdups. Okay. So yes, it has great outcomes, but unless you factored in the fact that in your current session, you may see, I'm making this up, but you might see 8 patients. If in the new technique you only see 4, that's not going to be a good thing. However good the outcome is, unless you increase your capacity and you can see the same number of people. You have to show that, because otherwise that's going to negatively affect the 2-week wait. So other things that you need to put in the strategic case or your case for change, you've got to put your problem in. Now, use all the data you can to put that in. So it can be things like benchmarking, comparing yourself with other organisations. It can be CQC recommendations, they carry a lot of weight. Mortality reviews, root cause analysis, the getting it right first time GIRFT reports, and the model hospital. All have good data and are good for benchmarking. NICE and Royal College recommendations are good, but you have to back it up, because if an organisation has to implement all the Royal College recommendations, it'll go, they have multiple Royal Colleges having multiple recommendations every few months, if not a few years, then it'd be hard to maintain all that process. So again, you have to back it up with the quality and the thinking behind it. They all add weight to your case for change. So again, anaesthetics one, apologies, but this is some data that is a bit old now, but this is when I took over a sustainability lead for my department, and I was tasked with reducing the amount of desfray. Now you can see that this is from Model Hospital, we were the blue line, and desfray is really bad for the environment, so there's a national NHS drive to reduce it. But we can show that we were way off. Our benchmarking was way off. We were a high user. So you can use this to go, actually, we need some other things that maybe to encourage my colleagues, my anaesthetic colleagues, to not use desfray and use alternatives instead. So I can use this to try and drive the purchase of different pumps that we can use an alternative to desfray, this gas. And I specifically looked at sustainability budgets. So you pitched it to sustainability budgets, and you got money for pumps, for equipment that I wouldn't be able to get necessarily through normal channels. So it's about selling it, looking at what the effect is, what the benefits are, use the drivers and use the information out there that's there. It's another one, again, straight off Model Hospital. This is some data that I think there's a business case currently going through at the moment. So our emergency capacity, so the problem is that we don't have enough emergency capacity for emergency surgery. The evidence is here on this graph, which shows that our length of stay for emergency appendectomies it's like, I think it's about 15% for length less, and we're well off. We're well within the bottom quarter of that. Now, when you look at the data and analyze it on another level, you go this and you go, oh, I wonder what the problem is there. You can show that actually it's not that they're waiting, having lots of complications, having problems post surgery. It's they're waiting 2 days for the surgery in the first place. So you can use that to then look at different options to increase your emergency capacity. Okay. So then you can then do the next bit, which is then your options appraisal, and go, how can we best improve our options of emergency capacity to then help reduce our length of stay and the wait for emergency appendectomies. Okay. Use it to drive change. The other aspects that you need to talk about in the strategic case are things like your existing arrangements. So what is your current status? What is the state of play? What's the problem? What structure do you have in place? Okay. Your business needs a current to future. So what is the demand? Are you seeing 100 and 200 cases at the moment? What are the future demands? Is it likely to increase? So last year we went from a 2-site general surgical intake to a one-site general surgical intake. We moved ones, but we didn't really increase our emergency capacity. So, you know, we were one of the biggest laparotomy centres in the country previously, and now we're even bigger because we moved from 2 sites to 1 site. So you can look at that and go, look, our capacity, the rate of laparotomy has increased, you know, 3% over the last 4 years. It's going to continue to increase 3%. So you can build that into when you're looking at your options appraisals. So potential scope. So what's going to limit, you know, what are you looking at? So the business case we're putting forward now is not to build a whole new theatre complex. That's what we need. We need more theatres. But what we're looking at now is actually potentially looking at, that's not within our scope of this business case. We're looking at utilisation of the theatres better. Okay, maybe into the evenings, multiple theatres into the evenings. Okay, so what's the scope of your business case? And what's going to, how far do you want to put it? You have to look at what your benefits are and your risks. Okay, so your benefits, and there's a new word that I learned when I was looking at this, disbenefits. So benefits are good things, disbenefits are definite bad things, risks are things that could happen. So you have to discuss all of that. Constraints and dependencies are what's going to limit your options. Okay, so constraints for us for this theatre case is the number of theatres. Okay, so we cannot run any more theatres during the day because we've got no theatre space. There's no theatre capacity. So that's going to be constrained. The most common constraint that people have is estates. So physical space tends to be the biggest constraint in business cases. Dependencies are other projects dependent on this project. So if you have one project, say there was one where they were building a new ambulatory daycare centre, orthopedic daycare centre, for example, and there was another business case for radiographers, okay, that were going to work in that centre. So the success of the radiographer project was going to, you know, case build was dependent on the smaller radiographer business case going through. So one is dependent on the other. Okay. And then what is your spending objectives? What are you actually going to buy with the resources that you're going to get? Are you going to buy more staff? Are you going to buy, is it space you need? Is it you building? Is it capital building? Are you buying something? What is it with your spending objectives? What are you trying to do with your spending? You're asking for the resource. And then you can do, you know, the other things that you can help do stuff are things like your demand and capacity modeling. You can look at your previous demand or how things have changed over the last couple of years, and then forecast how that might change. And there may be specific reasons why things might change because of national changes or just demographic changes. And you can look at your demand and capacity modeling. And that can be then put into numbers. So you can then look at so if you see how many CTs you needed and how much that's increasing, then you can look at how many additional lists that might be. Previously, when yeah, and potentially in the future, when income is dependent on activity for certain things, you can then look at how that affects your income a little bit as well. Depending on your tab, but you can build that in depending on the payment system at the time. So I put it in grey because some years that's valid, some years it's not, depending on when I've done this talk. So the economic case is all about your options and doing an options appraisal. Okay. So as I said, keep things quite broad. Identify the problem. Come up with a long list of all the potential options, even things you would dismiss out of hand because you know the area or the kind of the kind of project in detail. You put on your long list. Okay. You have your assessment criteria. So what are your, you know, in the same way as your job description, you have desirable and you have essential. Your essential criteria, your critical success factors. So well, these are things that have to be there, and you have your desirable. You can weight it. You can do all kinds of things to help with your assessment. You know, most important, least important. There's lots of ways of doing it. but you have to have some sort of assessment criteria, and then and your key things that you need that you can then develop your shortlist to. Your shortlist ideally should be at least 3 options. Okay. It must include a do nothing or do minimum option. And then there's 2 parts to the next bit. There's the economic appraisal, which is the qualitative benefits. So what are the actual quality improvements? What are the benefits for each of the options? Okay. How's that going to work? And then a rough cost appraisal of how much it would cost, to give you an idea of when you're comparing the different options. One way of doing it, of the options appraisal, is to do this kind of this table essentially. Okay, this is what's suggested in the Green Book. I'm going to use HS2 as an example because it covers multitude. Everybody understands the broad concepts and it's nobody's specific speciality. So this is, if you had a business case to improve the railway capacity or railway network capacity between London and the rest of England. Okay. So the minimum option would be to do a connection between London and Birmingham. Okay. The intermediate would be to London, Birmingham, and the northwest. And then the maximum would be to do London, Birmingham, northwest to Leeds in the northeast. Okay. So there are your 3 options. How you would do it: minimum is refurbish the existing tracks. The maximum would be to build whole new tracks, and intermediate would be a mixture of the 2. Okay. So that's how. Who's going to deliver it? So for example, you could do a local contractor, a national contractor, international contractor. In medical or in NHS healthcare, you could have consultant delivered, you could have ANP delivered, all kinds of things to who could be delivered. You'd have ideally a multidisciplinary team, and the minimum would be a clinic nurse delivering it, depending on what it is. So there's different ways you can do it. And then when is the timeline? You could do, the minimum would be to do 1 at a time. Intermediate would be to do 2 of them and then do the last one. And the maximum would be to all 3 simultaneously. And funding in this scenario would be completely government funded, or it could be completely private funded by increasing rail, passing on to the passengers, or it could be a mixture of the 2. So you have that as your options appraisal. Then you kind of red, yellow, green them essentially. You have red are the things that are non-starters. Your yellow are your possibles, viable things, and then the green would be your preferred solutions. And you'd have your justification for it underneath it, but it's clear to see all the things you talked about and why you've chosen what you've chosen. Okay. So broadly speaking, this is what we're going to talk about, or this is what we have. We have the strategic case. Is it needed? Why do we need to change? Risk and benefits, and the quality case. The economic case, which is it value for money? What options have been considered? And then what options have been chosen and why? So when we talk about the commercial case, again, this is where you have to get input from other colleagues, other services. I'm going to say apologies to the next speaker. We're running a bit over, probably be about another 5-10 minutes, hopefully, because of a combination of speaking delays. The procurement process is liaise with your teams about the procurement process, because you're looking at, when you're buying equipment, you have to look at the whole life cost of the bit of equipment. And by that I mean, if you buy a bit of equipment, and I'm going to use, again, anesthetics is what I'm going to use. We have a camera that a disposable camera that you can use, it's like a bronchoscope thing for looking in airways. Okay, so it's just a camera on an endoscope thing, and so you can have there's two ways of doing it. You can, in some companies might go, okay, the screens that come with it will give you for free, but the cameras cost £500 a bit. Okay. Another company might go, actually, the screens cost £100, but the camera costs £300 per use. Okay. But it depends on how much you use them. If you're using them just for emergencies and may only use 1 or 2 a year, you might find over the lifespan of the contract, and I would always recommend not having a too long a contract, because most clinicians like their toys and want the latest model rather than being stuck with old stuff. Or if it's a managed contract where they'll continue upgrading, that's great. But depending how much you're using, if you're using one every day or multiple every day, it might be cheaper to buy the screens and have the lower costs of the renewable, of the disposable bit. If you're not going to use very many, you might prefer to get the screens for free and have the higher cost of the disposable bit. Okay, so it depends on over what kind of period and how much you can use them, and how much the disposable bit compares with the upfront costs. So you have to factor that into the procurement process. There's also lots of procurement rules about, with below a certain threshold, you don't have to put it out for tender. Above a certain threshold, the contract value is, then you've got to put it out for tender, invite those tenders in, you've got to do a proper evaluation. There are lots of rules around procurement. Now, hopefully it'll be discussed later on today. Personnel requirements. So generally, you have to make sure that you have an idea of your personnel requirements. So what by that I mean, if you want a consultant to staff a clinic for every week of the year, and if you're thinking about a consultant contract is based on delivering 42 weeks of the year, you're actually needing a higher proportion. You don't need just one working time equivalent of a consultant. You need like 1.1. The HR tends to have that number. Okay. And same with nursing. Anybody on agenda for change, if they're on a 37.5 week contract, 37.5 hour a week contract for working to full-time equivalent, to staff a 5-day week service, you need more than one working time equivalent. Okay. If it's a 8 to 8 service, if you're looking at 24 hours, you're looking at 4.2 or something. You need a number. There's a number that you have to then put into your calculations for costs, because it's not just one person, it's multiple people to cover leave and all that kind of stuff. So always work out from, and then when you cost the consultant bit, you tend to go for the mid consultant tariff, and personnel depends on what band you want. Okay, you have to factor that in. You go for the top of the band, middle of the band. HR tends to know where to pitch it. Contract issues. It's always worth looking at whether you have ongoing contracts that may affect what you want. So that works both in terms of if you want a new bit of kit, but you're already under contract, or that the trust your organisation is already under contract with another company that provides kit, you may not be able to buy this new bit of kit until that contract comes out. You might find it easier to put your requirements into the bigger, trust-wide, organisation-wide contract. So if I want a bit of new kit that has a new type of programming in, we've only recently changed our contracts for medicine pumps. So if I want a new one, I have to wait till that medicine pump contract gets renewed, and I'll put my requirements in. It's harder then to get contracts off, to get those pumps off contract otherwise. So be careful with contract issues. There may be other things like just compatibility. So a few years ago, we bought a cardiopulmonary exercise testing machine. So it's a big, an exercise bike with all the software program. It comes with a laptop that's kind of built into it. And I'm making the manufacturer's names up, but say our trust had a managed contract with Dell, and this was an HP. We had issues with compatibility, which meant it couldn't be used for a couple of months while all that stuff was sorted out. So just be aware of the contract issues that you might have. The financial case is very much up to the financial teams. How you're going to pay for it so which budgets are going to come out from, and that partly is to do with who you're pitching it to. So again, we had we wanted to redevelop a part of our area to have a space for teaching and for office space, essentially non-clinical space. It was something that was we were criticised for by we had a health education England report, so we put in for some money to redevelop another area to make it into some office space, and eventually it was agreed, but it came through the education budget, which meant that we had to put in certain kind of caveats that meant that education will always take, or medical student and trainee junior doctor, doctors in training, education will always take priority over any other use. Okay, because it came from an education budget. So you need to work out what that's going to what you're going to do with that. How's it going to be delivered? Just again, that's part of the timeline. Is it going to be big bang? Is it going to be gradual? Are you going to pilot it? How are you going to do it? There have been places in the past in other parts of the country that may have got funding from a charity to trial or pilot a specialist nurse. I think they had a Parkinson's specialist nurse funded by the Parkinson's Society for a year, and if they met certain criteria, then the trust would then continue that funding because it would show the benefit. So it's part of there's different ways of doing it. And then finally, impact of service delivery is all about what are you going to do as you transition. So there's two components. One is how's it going to impact your service delivery? Is it going to negatively impact your service delivery? How are you going to do it while the transition phase is going on? Are you going to have to look at having temporary alternatives? What's your backstop? You can't be dependent on this thing going through because, for example, your contractor that's building a new hospital might go bust. That's happened in a couple of places already recently. It might be that things get delayed. So look at what's going to happen to that. At the moment of change, what are you going to do? We recently moved our transplant services from one site to another. Okay, so there were a 48-hour period where potentially kit was on one side, patients are another. If we need a transplant, we might have been struggled. So one of the things you can do is ask another centre to kind of look after our transplant needs for those 48 hours while we're doing that change. Okay, so there may be something you might have to look at when you're looking at the management case. Okay, and how that's going to factor in. So again, it's a whole process rather than just an individual thing. With all these things, try and get people to engage in them. Look at all the people that might be affected by your project, address their concerns, incorporate their suggestions, and get them to support you. The more people that support you, the more likely you're going to get your business case approved. People don't like change, so get them involved in the process and feel that they're part of it rather than giving the opportunity to block it. Okay. If you can get somebody to champion it, whoever's on the committees, if you can get somebody to champion it, that's always really useful and helps. My top tips are small business cases tend to be okay, tend to be more beneficial near the end of the financial year. Big business cases tend to be better off starting from the start of the financial year and then incorporated, as long as providing it's incorporated into the commissioning and discussions. Okay. Look at digital transformation funds or education funds because there are other pots of money around that may be suitable for your projects. And then look at system funding versus specialised funding, depending on who's going to be affected. Now, that differentiation may disappear over the next few years, but currently there is still differentiation between system funding and specialised funding. So if your process is going to primarily affect specialised funding cases, so our prehabilitation work is funded directly by NHS England because the cases that these are people who do exercises and a whole exercise process before their major operations. Those operations tend to be funded specialistly commissioned, so the specialised commissioners are the ones to target for the funding. And finally, it's always useful to combine with a larger business case because the larger business case tends to have more people involved, and £100,000 here or there in a £20 million business case is neither here nor there. So all might be able to piggyback onto one or the other. When you're doing business cases, just make sure that every diagram you put in makes sense. This is something I found in one of our, it was a award. It was looking for a bid for some digital transformation fund. And I don't know what periodic care impact means, and I don't know if it's a good thing or a bad thing, and I don't know what kind of timeline that You know, if you have to write more text to explain the diagram, it's a bad diagram. There are ideal business cases. The problem being addressed or intended benefit is evident. All potential should be considered and be a comprehensive rationale. Ask people to get involved. Have a good implementation plan. Contingency factored into the business case, and have realistic timelines. There are some oversight metrics. When you get the handouts, you'll get. These will all be in there. These links are for extra material if you're really interested and really keen to learn more about business cases. There are courses such as the Better Business Cases, and there's I think there's a foundation and practitioner. They are primarily for people doing business cases all day, every day, and for the big civil public sector business cases rather than NHS business cases. They have lots of gates and checkpoints, which we don't have in the NHS. So I wouldn't recommend doing it, but if you do want to know more, it is there. Any questions? That was very much a whistle-stop tour of business cases. And apologies, Ben. I have run way over than I was planning to.
All good. People feel free to fire in the questions while we're here.
No. Feel free to email me any questions. The standing offer I have, and only a handful of people have actually taken me up on it. I will happily look at any business case that anybody sends to me. If you want some broad advice, I'm not going to go into the nitty gritty, but you know, particularly those that are starting off, if you want a starter for 10, I'm happy to look at it. If you just email me. Fine. Well, we'd like to welcome Ben Galbraith, who's the Greater Manchester ICB Finance Programme Director at the NHS Greater Manchester Integrated Care System, who's going to talk about their journey to integrated care. The slides will be sent out to you in the handouts. Don't worry. And I think this is recorded, so you'll be able to watch it back and be able to catch up on all my fast rambling.
Lovely. Thank you very much. I will just share my screen, I think. Hopefully you can see that. 1 second. Okay, so I can see the chat and my screen as I'm going. So just if you pop things in the chat, I'll try and take questions as I go through. I haven't done this before, so hopefully this hits the mark. And apologies, wasn't able to join this morning. Having looked through the agenda, saw there was a session on commissioning, so hopefully I'm building on that. But having, as I said, having not had a chance to see the slides, then just kind of apologies if there's any disconnect here. So what are we trying to do? Just conscious that you've got a lunch break due in 20 minutes. I don't think I'll quite get through in 20, but I don't think it'll be long over. So let's see if we can catch up. So something about the development of ICBs and ICSs, integrated care boards and integrated care systems. What is all this? So I appreciate this is a very mixed group. I've been seeing some of the chat come through, and obviously kind of different mix of clinical and managerial folks on the call. We all have our acronyms. This is absolutely no exception. So there's a whole bunch of them here. I'll go through some of these definitions in the slide to kind of work it through in the Greater Manchester context. ICB, Integrated Care Board, is an organisation. So that is now kind of come from what was CCGs. In some cases, that's been a one-to-one. So if I think of, say, Lincolnshire, in Gloucestershire, I've got a list up in a minute. And in some cases, Greater Manchester being at the extreme of that, that's lots of organisations going into one. But the ICB, the board, is the single entity. The ICS is then the system. Slightly confusingly, it's used in a kind of colloquial sense to mean everybody in the system. So from hospice, local voluntary organisations, through local authority care homes, GP practices, pharmacies, all the way through to the major NHS trusts and the ICB itself. So it could be a system meaning everyone's system. It can also be a system meaning the pardon me, the just the NHS organisations. So in finance regulatory terms, when NHS England sends out an email saying the Greater Manchester system target is blah for, I don't know, reduction in 78-week waits or something, or financial balance or whatever it is, what they're talking about is just the NHS organisations within that area. So it's one of those words which unsurprisingly means something to everyone. ICP, the Integrated Care Partnership is a group. It's a board, a committee meeting itself. It tends to have a very wide representation, but it tends to be representative representation. So you won't have in Greater Manchester we have 9 NHS trusts. You wouldn't have all of them on the partnership. You'd have representatives. And again, VCSE, I think thousands of voluntary care sector organisations in Greater Manchester. They have a number of umbrella organisations. Tend to have one per borough, but there's also one across Greater Manchester. And again, those are the representatives there. As with primary care, IS is independent sector or private private hospitals tends to mean. So kind of the Bupa, Spire, etc. Place is local area. So place is a piece of language that's used specifically in the kind of the legislation and the setup. It tends to mean borough in most of the areas, but not always. So it tends to be coterminous with a local authority or a metropolitan borough area. And then provider federation. Very, very mixed in terms of how they're set up legally, but it's some kind of alliance of people working together. And I'll run through a few of those in Greater Manchester. So definitions. A fair mouthful of things to look at there. And then how does that work in Greater Manchester? So I suppose in Greater Manchester, we've got the orange blob up here, which is the care board itself, the organisation, 2,000 members of staff, £6 billion of allocation coming in, and a commissioning organisation. So, been through that this morning in terms of what commissioning is, but the ICB is the commissioning organisation. The ICP then has ICB, and the example here is local authority, ICB, Healthwatch, other partners, but absolutely partners from across the provider spectrum. And then in terms of, and those are the kind of big entities, but then down the side, here we've got the geographical footprint. So system, usually 1 to 2 million. Greater Manchester is 2.8 million residents, second largest in England. Place, 250,000 to 500,000 people usually, but to fit with something sensible. So in Greater Manchester we have 10 local authorities, and they kind of range from, I think, 170,000 is the smallest up to 700,000 is the largest. So a bit of a range in there. And then neighbourhood. So certainly in the boroughs I'm aware of, I think those have been PCN footprints, primary care network footprints, which are now coterminous after a jiggery-pokery with local authority wards. Sorry, someone just said they're not able to see slides. Can someone, everyone's got their cameras off, which I assume is deliberate. Does someone want to shout and tell me if anyone can see the slides?
I can see them.
Yeah, I can see them too.
Yeah,
Okay.
I can see your slides.
Great. Okay, no, brilliant, thank you. In which case, sorry, whoever that was, you might just need to log out and log back in again. Or possibly if you clicked on something, just click on there might be a small icon of the slides up on the screen. Thanks everyone. I'll keep going. Neighbourhood, a ward, a borough. So in Oldham where I used to work, we had 5 wards, primary care networks. In the NHS jargon, that's 30 to 50,000 population, and those kind of similar. So its local authorities have broken down to be a number of kind of a few chunks of their population that they're looking at in terms of arranging services that they commission and they deliver. So we've got a board, which is an organisation in Greater Manchester, 2,000 staff, £6 billion coming in. The partnership, which is setting the long-term strategy and being the kind of overarching. So those tend to be quite big bodies. Some criticism on the early legislation as to whether they were too big, but that is the nature of engagement, of course. And that's setting a long-term strategy. The board's making the formal decision. And I suppose what we then get into is how do you do the work? So if you're doing those business cases that the gentleman before was describing, how are you deciding what are the priority business cases to do and what bits of work you're doing? So I'll come into that. ICS is across the country. Apologies, I nicked it from somewhere, third hand, I think. So apologies, it's slightly fuzzy. I suppose the point is just to see there are, I think, 43, if memory serves. 42, apologies. 42 in total. Very varied. If you look at 1 and 2 up on the top right of the country picture, they're Humber, North Yorkshire, North East, North Cumbria, very big geographic areas with less dense. And obviously, if you get into London, then the 5 London ICB footprints, much smaller geographically, but obviously hyper dense in terms of urban environments. So, and mostly obviously a bit of a mix. But really big both in terms of geographic size, nature of populations, and of course, kind of the component parts. So Greater Manchester having very big specialist hospitals, kind of probably second to parts of London, and then again with Birmingham. Sorry, someone's got their microphone off, so you can just check, please. So that's kind of a bit of the what is an ICB. I appreciate we're rattling through at high speed, and your brains are going to be full before lunch, never mind for the end of the day, I'm sure. But in terms of just, there is a commissioning organisation with loads of staff and where the money comes in centrally. That's got a range of partnerships that it engages with across, I'll just go back, across the system. It's operating at a number of system levels. So some are much smaller and maybe don't have places. Most are big, multi-million population, and do have that broken down and work at several places with local partners, local authorities, local hospital site. So there's real complexity in there in terms of how you're working through. Back to the previous gentleman's point about, how do you know how to engage, how do you figure out how you reach into those different parts? And I think, in Greater Manchester, we've got a couple of organisations, a couple of NHS trusts that are multi-site hospitals where they have site leadership, and those guys are actually the ones linking out with the place leads and the local authority chief execs. So it's about going up through your organisation and finding those links, but they will be there somewhere. But it might be a few steps removed from where you're kind of, where you're operating. Greater Manchester itself, I'm just going to skip through a bit, but that was something I didn't fully know. Greater Manchester, very proud of the GMCA and a lot of work that came out of, tragically, the bomb in Greater Manchester, bomb that happened in the IRA many decades ago, and devolution that built from there. But many, many stages, and lots of those are not including Health at all, so you can't read the words unless you've got a particularly big screen in front of you. But many layers of building up the devolution infrastructure in Greater Manchester and in other big city regions about how they're working together. GMCA is the GM Combined Authority, owns Manchester Airport, amongst other things, and is a kind of vehicle from which the 10 local authorities work together. Andy Burnham, as mayor, is leader of that organisation. So, political leader. There's a huge infrastructure there in Greater Manchester that we've been on a journey with over many years. Deal 2, with the prettier picture. I note that the NHS one has the prettier picture on the cover, whatever we make of that. But deal 2 is that NHS devolution deal. So there was a big chunk of money that Greater Manchester system got as upfront on a whole bunch of other things that happened over the years. So there was a devolution deal negotiated at the time with George Osborne as Chancellor back then. That allowed certain freedoms, not huge operationally, but there was a bit more in terms of the way it was done. But that was actually one section, was the NHS section, and there's a bunch of other sections. NHS Greater Manchester as a system, 10 boroughs working together, both in the local authority side and in many of the other aspects of public sector services. Big journey, big long distance travel, and lots done over that time. I suppose that's, obviously I know the Greater Manchester system. There's a lot of other stuff going on outside of our organisations that we don't see day to day. And I suppose that's my point here is that becoming a system, these ICSs are about working on a bigger scale to get bigger benefits because you're doing things once across a bigger footprint. Also, a lot of these commissioning decisions, we don't need to make a lot of different commissioning decisions in different areas across our cities because there's a lot of commonality across that. There won't be in all parts of the city, but actually you've got kind of common needs in different parts of the city that you can meet once. And you can do it better by working together. So system leadership and governance spanning NHS, local government, mayor, combined authority and voluntary sector. And that first bullet point, a lot of joint working, which was working together in terms of bringing together the different pots of money coming down from central government, whether that's through education, through transport, Greater Manchester Transport Authority, whether that's through the mayor, local authorities pooling their funds to do some things together, as well as obviously the NHS money's coming in. So all those different funding streams working together about how do we help patients, how do we help residents, stay happy and healthy and not need the NHS services. Obviously, we want great services when they need us, but we kind of want people not to need us in the first place. And all of that is done before people get to the NHS, and that's the importance of big plank of deal 2. Just to go back a slide, big plank of deal 2 was about population health, about health inequalities and understanding and addressing health inequalities, and thinking about how we do that differently. A lot of which obviously is very strongly written into the new NHS objectives kind of coming through in the past couple of years. So Greater Manchester ICS, it feels like it's kind of evolved from a previous thing that was 10 CCGs working together and coming in. So Greater Manchester ICB, the entity, the organisation, we had 10 CCGs across Greater Manchester on the same footprint as the local authorities, with a small area called Glossop on the eastern border, which has now gone into Derbyshire. There was a shared services, what was Greater Manchester Commissioning Support Unit. You may have a CSU in your area that you work with. And that was several hundred staff, mainly doing IT services, but some other things as well, so particularly GPIT. And then finally, there was a devolution team. So that devolution deal that was done, kind of whatever it was, 5-6 years ago, that the partnership with the team that were kind of overseeing and managing that project, and they came in as well. So that team's come together from a lot of areas. And we're still, sorry, let's get past that slide. Oops, sorry. So we're still working together in those different ways. So there's still some read through from the partnership team and the NHS England area team that has become the Plan GM team, the teams that work across the area. 10 localities, because those places are really important in terms of joint working with local authorities, and obviously kind of social care providers and primary care. There are, I think 800 plus primary care practices, GP, pharmacy, optom, dental, across Greater Manchester. You can't have 800 relationships from a central office in the middle of Greater Manchester. Those local relationships, we'd say the 44 GP practices as was in Oldham, you need to manage those locally, a set of local relationships where you understand each other and can build on what you're trying to do. And equally, the GP practices, again, having roots into their communities, their local social care providers, their local community monitoring community services. So those places are really important and have not gone away just because we've formalized that superstructure of the top. And then the neighborhoods, 66, and those are the PCNs, the 30 to 50,000 people I was talking to before. So those are parts of the local boroughs. Operating at several levels, operating in different ways in terms of the ICB and providers and so on. And that's a very complex structure. So just to pause on there, one of the things I would just add into this is I think the ICB, and certainly Greater Manchester, and I know in other areas talking to colleagues elsewhere in the country, that complexity is real, is difficult. So some areas people had one CCG becoming one ICB. In the north of England, particularly, those mergers happened 1st of July. So we had 12 organisations coming into one organisation on the 1st of July last year in Greater Manchester. That's a lot of change. There's a lot of governance, and we were working on all those levels before that are on the screen now. So we're working with PCNs, we're working as boroughs, we were working across Greater Manchester, but we're now doing it in a single legal entity. And so the rules are different for some people, the rules are similar for others. I haven't seen as much change. The committees where you need to get stuff signed off is different. The who can sign which bits of paper is different. What are the bits that are delegated to which groups are different. So when it comes back to the basics of I'm trying to do a business case and I'm trying to change something and make something better. Where do I go? Has all just shifted a bit and is a bit uncertain. So I think one of the things I would say about devolution is for Greater Manchester, it's a journey of decades. But this last year has been a bit of a wrench of something that was kind of there. And that jolt has just upset the jigsaw pieces and they're not quite settled back into place yet, is how I would describe it. So that said, the jigsaw pieces are there. They were there before, they're going to be there tomorrow. And we're just having to sand off some of the edges, get things back in place before we can really start motoring again. So there's definitely a bit of disconnect and a bit of edginess about making things work at the moment. Current view of the role of the ICB, slightly more generic kind of statements here. An integrated commissioning board is system leader is I think the phrase that's in the legislation and in the kind of CCG and ICB guidance. There's a role of kind of system convener, system leader, bringing people together. Particularly PBR, a payment by results, the old finance system pre-COVID, really drove behaviours of people kind of working a bit internally, naturally. And that would be to try and do things efficiently and effectively for patients and look after people. But it didn't necessarily encourage people to reach out beyond the boundaries of their organisation. So there's always been a strong role for commissioners to pull people together, pull different parts of that system together into joint and to encourage the joint working. And that's absolutely still there as ICB. So the chair of the Integrated Commissioning Partnership is frequently around the country the chair of the ICB. Not always, it's a bit of a mix, but that's there. Commissioner. Hopefully you got that described to you this morning, but commissioning is understanding the needs of the population and then trying to respond to those. To some degree, you might try and shape them in terms of encouraging some behaviour change, whether that's stop smoking or do a bit more exercise. And there is a whole GMCA strategy on Get Manchester Moving. I'm sure you have similar things wherever you are. But the commissioning role is there for the ICB to decide, there's £6 billion coming in. How is that best spent? Contracting authority, by which I mean just it's the legal body that holds the contracts. But with that obviously comes, as previous gentleman said, the procurement regulatory process, the contract management process, the contract oversight process. ICBs are not the CQC, they're not monitoring quality of services, but when the CQC says something's a problem, your commissioner, whether that's ICB or specialist commissioning or whoever, absolutely then is at the table, and hopefully is at the table before that. And funding flows. Which way round does the money flow and what are the rules on how that works and who makes what decisions? Come back to something I mentioned earlier in the talk. We'll talk about kind of the complexity. So I'll skim back up a few slides. Yeah, apologies. This slide here. So I was talking earlier about the role of kind of the board and the partnership, as well as provider collaboratives, which are probably kind of in the middle here, those groups of providers working together, whether that's primary care or NHS bodies or voluntary sector, and then working out system and borough and neighbourhood level. So you've got, that's a 3x3 grid, and that middle column of provider has got 3 within it, and the complexity just gets really, really big pretty fast. And all of those got their own system boards and working groups and so on. And you sit there and you think, right, I've got this thing I want to do. I want to write a business case, but where am I taking it? Who am I engaging with to get it there? And what's my route through? And do I have to go to the, I don't know, the urgent care board in 10 localities, or do I just go to the one in Greater Manchester? And that's what I meant by the jigsaw puzzle being shuffled up and then not quite settling down. Everyone's looking for kind of, we're having to do a bit more engagement during the times of uncertainty than we would hopefully at the end point. Sorry. Skim down to the end again. So the funding flows, my reflecting back there, if we've sliced and diced things into many different kind of bits on this grid, who's making decisions on that money? So when the government kind of makes an announcement that says we're investing £500 million in discharge support for the winter, and Greater Manchester's share of that is £30 million. Who then takes charge of that £30 million and makes the decisions on which business cases are going to be approved? And is that done at kind of GM level, a locality level? How is the money split out? If we're trying to address health inequalities, we don't just divide by the number of people in each borough. And I saw some comments earlier about kind of looking at different populations. So, you know, is that based on age? Is it based on number of hospital beds? Because I don't know, if there's loads of hospital beds in Tameside, maybe they need more of the funding because it's discharge money. So is it particular to that thing? Is it more about whether the care home beds are? And that's those are the areas where we're going to kind of get the greater funding out. So how you split the money, deprivation, heads, age, sex, disease prevalence, etc., is not trivial, and of course gets very sensitive because of course you can make an argument for any of those things, and they give you different answers, and everyone wants, you know, to look after the people that they're working for. So, you know, in Oldham they're fighting for the Oldham residents, and in Tameside the Tameside residents, and that Socratic debate can get a little fun at times. Final bullet point on this slide, and this is my penultimate slide for those looking at the clock. Regulatory oversight, emergent and mixed approach. Mixed in that it feels different when you talk to different parts of the country about what regulatory role do we have as an ICB. So the CQC are absolutely the ones who are inspecting quality of services, but in terms of regulating, I don't know, how are different NHS providers in Greater Manchester doing on meeting their elective waiting list targets, for instance? What's the role of the GM ICB? What's the role of the Northwest Regional Team? What's the role of the National Elective Recovery Team? And again, back to my kind of shuffled jigsaw pieces, it's a bit overlapping. I think it's more overlapping than gaps at the moment, and things still settling down. But as I'm sure you're aware, NHS England going through their own merger in terms of NHS-EI, AGE, and so on. So that kind of that part of the system's moving as well. And then how do you be regulator, which can tend a bit towards the kind of, you know, the school teacher zone, and system convener and joint worker and encouraging partnerships at the same time? Regulator tends to be, sadly, it's more often than not, hey, we understand why you haven't cleared all the 78-week waits, but you haven't cleared the 78-week weeks and we need to do it and what we're doing about it. And, you know, tougher conversations, partnership working tends to be how do we work together to get that done? Absolutely, there's an overlap there, but those things can be tricky to balance. And my final slide. Where is the ICB going? In Greater Manchester, what feels, if you read the called Taking Charge strategy, the devolution deal 5 years ago, the NHS was involved in, deal 2 of 9, as I've learned yesterday. And then you look at the new strategy that's out for consultation at the moment. There's a lot of overlap there, which is great because they're long-term goals. You wouldn't expect them to get done in 5 years, changing habits of 3 million people and lifestyles and health outcomes. But there's kind of there's an evolution there, which is really good. Again, where does the ICB itself evolve into? And what's that? So firstly, what's that balance of system leadership and partnership working with regulation and responsibility for delivery, for the delivery of constituent parts? Secondly, I've avoided some jargon here, but commissioning and service improvement. So again, if you were listening to a conversation about commissioning this morning, understanding health needs and how best to meet them is kind of one way to describe commissioning. If you're inside an organisation, you'll probably have inside a big NHS trust, probably have a service improvement team or a quality improvement team or multiple versions of that within that organisation. The overlap there is quite strong, particularly where the commissioning stuff gets more detailed and the service improvement stuff gets broader. There's a really big overlap in there. So how do we do things once with a single team rather than having two competing teams both trying to do things in different organisations? So that bringing together, it was kind of a discussion about tactical and strategic commissioning. If you go back a few years, it now seems to be more about a conversation about, system collaboration and service improvement, and do it once as a system. And finally, funding flows, and by which I mean, how do we divide up the money between different parts of what are some very big organisations now, £6 billion, 2.8 million people, residents being served, how do we divide up the money across that population in a way that's fair? Because fair is ambiguous, it's subjective, and there are many ways to get there. I gave myself a 20 past deadline and I've run 2 minutes over, which for those who know me, if there's anyone out there, is pretty good going by my standards. And apologies that you are then 7 minutes late for lunch. So, thank goodness you've come back on. I was just wondering who was doing what and wrapping up for lunch, but I haven't seen any questions, although no doubt impending lunch break is part of that. Appreciate people need a bit of a time off. I'm happy to stay on for kind of 5-10 minutes and just see if any questions pop in the chat, or if anyone wants to stick their hand up. But I don't know whether you want to. Sorry, are you chairing, Akban, or are you just popping back in? Sorry,
No,
your camera came back on my screen. Apologies.
No, I'm kind of chairing in some sense of the word. So thank you very much for coming along and speaking today. Does anybody have any questions? So if not, again, thanks, Ben. This is kind of at the end of the plenary part of the session, the day. The afternoon is very much more pick a mix for the sessions that you wish to attend. Some are more useful than others, depending on your organisation and your role. So feel free to pick and choose as you wish. But if not, I'll hang on for another 5-10 minutes. If you have any questions that are specific to anything in the day, we'll try and answer them. We'll find someone who can. But thank you, and we will see you all later.
Good afternoon, ladies and gents. My name is Mark Ibbotson. I work for an organisation called the Healthcare Supply Association. I'm the Learning and Development Lead. My kind of background is I've been a director of procurement within the NHS. It's a major university teaching hospital. For the last probably 15-20 years, I've also been, on top of that job, a teacher and a trainer in all things procurement. So I've got a brief presentation for you, but I'm also quite happy to take questions. If you want to stop me, can you please identify yourself by putting your hand up, whether it's at the start, the beginning or the end. I'm quite happy to take it at any stage. So the mystery of procurement. Procurement is a support service to all you guys. It's not here to stop you doing anything. All it's doing is it's here to help you achieve what your goals are. Now, there's some very basic rules within procurement, and we have what we call the 5 rights of procurement. And these 5 rights are about achieving value for money. So we have quality, quantity, price, place, and time. And those are all traded off against each other. So the right quality, right price, right quantity, right place, and right time. If you want your goods or service here tomorrow, the chances are that the price will go up. Delivery charges, etc., etc. If you buy more, normally you'll get a discount. So what we're saying is principally that we will trade these things off. If you want top quality, you normally have to pay top price. If you want cheap and cheerful, you pay a lower price. I'm not suggesting that you do want to do cheap and cheerful. However, these are, as I say, are all trade-offs. And this is what we in procurement are there to do, to help you plot your way through all this information that you get. So sometimes you'll get a situation where somebody said, this is the only place you can get it. We'll try and say, well, okay, you can get it from here, here, and here. But at the end of the day, whatever you want, we're here to get. Okay. So we start to look at the supply chain. Now, we've all learned in the last couple of years about the supply chain to a greater degree when we've been searching for PPE to make sure that we can give correct patient care to anybody who needs it. So the activities required by the organisation to deliver goods or services to the customer. That's from our professional body, Chartered Institute of Procurement and Supply. And basically what that means is from where the goods are sourced to where they're manufactured. So it might be raw materials, manufacturing, there might be a wholesaler involved, there might be a third party involved that's going to deliver it, and then it gets to either the hospital or the community area that you require. So it's about managing that supply chain. And obviously we had significant changes in supply and demand when we had COVID, and we learned a lot during that period. Excuse me. We learned to use things that we could get from a number of different places. It brought us on new suppliers. It changed existing suppliers. So what we're there to do is to try and manage this to make it as slick as possible. So at the end of the day, when you go to a bin or a basket to pick some product up, it's there ready for you to use at the appropriate time. Okay. So we do have some rules and regulations that we have to follow, a bit like you will do in your professional practice. The rules of our game are the standing financial instructions, standing orders, which are probably as dull as dishwater, but nevertheless, they are there. We have to follow them. And it will tell us what we can and can't do, how much we can spend, up to a certain limit without going out to quote or tender, who has authority to spend that money, etc. We're also driven by a series of statutes, regulations, Data Protection Act, Public Contract Regulation Act, and all these are going to change over the next 12 months. Because we've come out of Europe, we're no longer part of the EU regulation. We're still working in principle to those at the moment, but we will be coming out of those, and we will have to have our own, and that's what will govern us. So if you just want to go out and buy something, then that's fine. What we have to make sure is that we're following all these rules and regulations, which is why I say it's the dull bit, because that always appears that we are saying, no, you can't go and do something. It's not that we're saying no, that's not what we want to do. We want to make sure you get the stuff that you need to do whatever you do in the hospital or in the community. And it's about us navigating you through that. We look at a number of areas around what is value for money, and value is based over outcome over cost. So if you're in orthopedics and you want to do a revision, let's make sure you get the right tools for the job, because if you don't get the right stuff, then you'll have to do a second revision, and that will obviously cost more money. It's not about being cheap and cheerful. It's about making sure that it's value for money, and it fits in with the overall strategy of the trust that you're working in. Okay. What we have to do is we generally follow this kind of model, this procurement cycle. So we understand what the business needs are. We'll start to look at putting a specification together, or you guys put a specification together to work out what it is you actually want. We look at the market. So we had a change in market while we were looking at COVID. There was a greater demand than there was supply. That wasn't the norm, or that isn't the norm for us. We are starting to look at people like Johnson & Johnson. They have a very high market share. They're a very expensive company. Their product is very good. So we have to say, well, what options are there? Again, using that or finding different suppliers. We'll then decide how we're going to go to market. Now, of course, this all takes time, and you're sat there waiting for the stuff to come. But we have to go through this due process. And there are certain dates that are sat around it. So we like to test the market to make sure that we're getting competitive bids coming in, documents are developed, and then eventually we'll go through a tender evaluation, which you would obviously be part of, and have a big say on the technical merits of the product or service that we're looking at. Because if you wanted to buy tins of beans, well, they look like a tin of beans, they taste like a tin of beans. But if it's some clinical working, I will understand some of it, but I won't understand all of it. And that's where you, the experts, are involved within that process. Then we'll award the contract, and there's certain rules about that. And we may end up with a challenge. If we haven't followed these rules properly, then companies can put in a challenge and stop the whole process. And eventually we can end up in court having to justify or quantify why we've done what we've done. So any notes that we've scribbled down may actually be called to go into court. But then we get the contract, we award it, everything's nice, everything's happy. We then need to measure and monitor that performance with your help, because you will know whether the contract is working or not. And we will help support that. If suppliers aren't doing what they should be doing, then we will support you in making sure that they do what they're supposed to do. If there's change into the contracts, because all contracts don't stay the same for their life of the contract, they may things change. So it may well be that you shut a ward down, you open another ward up, or you close a hospital and open another hospital. So, you know, even the place of where it's got to be may well change. And what we're hoping there is to get continuous improvement. What can the supplier bring to the party? What can we bring to the party? Can we do things differently to make the supply chain slicker and faster? And what can the supplier bring? New product, innovation. And then what we also need to do that perhaps you're more used to doing in clinical practice is what lessons have we learned? We probably spend a bit too much firefighting to actually sit back and take stock. So what I'm saying is here, we're here to support you. We have a process that we follow. That process is flexible to a certain degree, but we want to make sure that you get what you want, that it's suitable for the purpose, and that we've taken everything into account that you guys need to make your jobs greater. So that was a very brief presentation. I know there's a lot of people on the call. Do you have any questions? I will do my best to answer them. If I can't answer them, then I'll come back. But what we quite often find is that people have either specific questions or their friend may have a question that needs answering. And that's what I'm here to do. So please feel free to ask me a question. If you can stick your hand up through the chat, then I'll come to you in the best kind of order that I can. So anybody want to anything answering? Nobody? Okay, well, oh, hang on.
There's a question in the chat.
Right, they're going through. Eva has no further questions. Can you explain the link between the NHS supply chain and EROS? The simple answer to that is no, I can't, because I don't understand what you mean by EROS. If EROS is a procurement system, then that will just be that they NHS supply chain run it. What I'll do, Helen, is I'll find out the information and I'll come back to you if that's okay. Oops, yeah, helpful. Doesn't look as though there's any more, Becky. So I'll find out about EROS and supply chain, and I'll bring it back to you, Becky. If you'll then forward the answer on to Helen, I'd be grateful.
There's one more question in the chat. Do you look for the best supplier for a particular product?
Do I look for the best value? One of the issues that we have is that people will always have preferences about a supplier. First of all, we need to make that the supplier can do what we want them to do. I've done some cracking deals in the past, and the supplier hasn't delivered because they delivered something, the same product to somebody else at a higher price. So we have to be careful. It depends how we quantify best as well. Does that mean deliver on time at the right place? Going back to those 5 rights of procurement. So it's a bit like quality. People define quality in different ways. My idea of quality of something may be different to somebody else's. So what we will do is we'll do a supplier questionnaire to make sure that A, they're financially stable, B, that we're not overloading them if we award them a new contract, or that we are comfortable in the way that they operate. So things like the Modern Slavery Act, we're not bringing in product from areas that are seen as not giving their workers a decent standard of living. So I hope that answers your question. Anything else? Best supplier. Was that for this one? Any more? Okay, well, thank you very much for listening. As I say, if there are any questions, you can either send them to me direct or, oh, hang on, we've got a new question. Oh, send them to Becky and she will forward them on to me and I will answer them to the best of my ability. But thank you for listening and good luck with the rest of the presentations.
Thank you.
Right, sorry about that. Hello, everybody. I'm here to speak to you about, well, an introduction to clinical coding. My name's Coral Nicholson. I'm currently the finance lead for clinical policies and service specifications at Specialised Commissioning, part of NHS England. That's my old job title, as we're in the middle of another restructure. But anyway, that's what I am currently. So what we're going to cover today, well, there's a number of things, but mainly all linked to this clinical coding. So what is it? What are the types of codes that we use? So we use ICD-10 codes, OPCS codes, HRGs, and TFCs. I'm sure there are lots of other codes as well that we use, but they're the main ones when we're talking about specifically clinical coding. And I will be covering why is accurate coding important. So what is clinical coding, first of all? So it's the translation of medical terminology as written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking medical attention into a coded format, which is nationally and internationally recognised. So what tends to happen is, the patient comes in, they have their first of all, we need to diagnose what's wrong with them. And then, of course, we need to give them treatment. So once they've had their treatment, the patient goes home. And then we need to enter all this information into the PAS system, so the patient administration system. So this is where, and I am not a coder, so I don't pretend to know the exact detail of how things are coded, but I think this is the general gist. Basically, the coders study the records, and the records tend to be the sort of medical notes. So if any of you are doctors, it'd be helpful if you could try and make your handwriting as clear as possible. So the coder is attempting to find out, what the diagnosis is and what procedures and treatment the patient has had, and then they check against the sort of national coding standards, such as the ICD-10 codes. And they will assign a code eventually. And if there's a national coding standard, that's great. But if not, there may be local codes that will be assigned. So there are two types of codes initially. The first one is the diagnosis code. So this is called an ICD-10 code, which stands for International Classification of Diseases. And then secondly, you have something called an OPCS code. So that is the actual treatment itself, and it's a classification of interventions and procedures. So both of these are used, and I tend to, whenever I need to work out how, what an HRG is, I'll come to that in a minute, I have to look into the COTA group. So later on, I'll show you what this code to group is, but basically it's a list of where all the ICD-10 codes are and all the OPCS codes are, and a bit more stuff in between. So I'll just give you an example. So 15 years ago, I was pregnant with my first child, and it turned out that when I had my second scan, they picked up a hole in the heart, so also known as a ventricular septal defect. So 3 months in, and unfortunately we had to have open heart surgery. So there she is recovering straight after the operation. That was at 3 months old, as I say. And then about a day later, she was a totally different baby because she'd had this treatment. And that's about another 3 months later on from that. Again, totally different. We're really pleased that she had this treatment. So she was diagnosed, as we say, with a Q210. So that's the ICD, the diagnosis code, a ventricular septal defect. And the procedure, the OPCS code, was a K13.1, percutaneous transluminal repair of defect of interventricular septum using prostheses. So why is accurate coding important? Well, for me, being in finance, of course, I think this is one of the most important things. It's used as the basis for payment. I mean, I've seen on your agenda of today that you have had some discussion about how the NHS is now paid generally, and how, you know, I'm sure you've had a discussion about how it's going to change. So I specifically haven't covered that in my presentation because it is a bit of a nightmare as things are changing so much. But anyway, the general gist as the basis for payment is you take the ICD code, which, as I've said, is the diagnosis code. You take the OPCS code, the procedure code, and that will give you an HRG. Usually it's driven by the what the procedure is. So HRG stands for Healthcare Resource Group, and it's basically, you know, standard groupings of clinically similar treatments. So for example, there'll be an HRG for a hole in the heart, and there will be an HRG for something like, you know, having a filling, a dental filling, and of course the two HRGs are going to be totally different, and the one for the hole in the heart is going to have, you know, going to be linked to an HRG which is much more expensive than one which is like a simple filling. So the data is processed, and in terms of trying to find out what that HRG would be, we could then, once I know what the code is by looking in the code to group, I would look in the Annex A. So this is part of the national tariff. We're no longer called national tariff though. We're now called the NHS payment scheme. So in the Annex A workbook though, it has all the lists of the HRGs that are available. And then you'd look it up and that would tell you how much the national tariff would be. If it's a local price, that would be slightly different because that will be a, you know, a locally agreed rate. So let's see what else we've got. So my example continued with my daughter. So, you know, I stated what the diagnosis, can't remember what that is now, the diagnosis and the procedure code was. When you put it into the code to group, out comes this HRG. And this all this shows is that there's 3 different types of HRG with slightly different complication scores. I think she didn't have anything else wrong with her, therefore she'd be in the lowest bracket, really, meaning that, you know, the trust would have been paid the lowest amount for her, you know, which is a good thing from my point of view, obviously. And just to show that we've got, you know, either day case unit prices or electives, they're the same, or if it's an emergency, then that will be, you'll get, you know, the providers will get paid more for emergencies, as you'd expect. And it says guide prices here because, as I say, there's now a slight complication. It's no longer a national tariff payment by results. We're moving away from that slightly. And then just to say that, you know, the you know, that it was a good, you know, it was very good. The outcome of the operation was good. And of course, she's now a teenager today. And that is exactly what she looks like. That is just a stock photo from the internet, but that is what she looks like, as do all teenagers, I'm sure. Anyway, so what are the scope of the HRGs? Well, this literally it comes straight from the Annex A document itself. So elective inpatients and emergency inpatients, as I've said, are covered. Direct access and outpatient diagnostic services. So all those different types of scans. Again, we've all got HRGs for those and specific national prices. Direct access and outpatient nuclear medicine services, unbundled chemotherapy delivery, and unbundled external beam radiotherapy. But what isn't covered in the same level of detail is outpatients. So they're all coded to four HRGs only, WF01A and B. So A being basically follow-up attendances, single professional, and follow-up attendances, and first attendances, single professional. So that means that if you go to an outpatient appointment and you're seeing a single consultant for a particular specialty, whereas the WF02A and 02B, they are for multi-professional. So sometimes it would help if a patient turns up and two specialties are there to be done in one go, and in that case the provider will be paid extra money. It won't just be the basic outpatient attendance price, so they'll get a bit more because you've got two consultants, if you like, there instead. And then the only other thing is that it's broken down by TFC, and TFC is treatment function code. And all it means is, you know, if for example, in the case of my daughter, we still go to cardiology outpatient appointments. So the treatment function code there would be 321 for the paediatric cardiology service. And of course, you've got all different ones for all different types of specialties. And I can show you anyway. I'll show you later. You know, I'll quickly show you the Annex A and how it's broken down, because it's easier to visualize when you see something. So which HRG? So when we come to trying to decide which HRG, there are a number of things that you know, decide on what tariff will come out and what sort of cost will be associated with that. First of all, admission method, as I've already mentioned, elective and non-elective, so emergency, you'll get paid more for. So depending on which one it is, will determine how much money you get. The length of stay is also important, going to that in a minute, and age. So often with, I mean, in this case, I've taken a particularly bad example because the descriptions of the HRGs don't have age-related information there, and that's because it's congenital heart disease, I think. But often in other HRGs, you'll have, you know, intermediate procedures for whatever ages 18 and under, and then you have the 19 and over ones as well. So, and of course the children's ones, you get a high tariff for those usually. And then the length of stay, that's, as I say, that's quite important, because for every single HRG you have, you know, as you can see here, the trim point. So the trim point is the number of days that it's expected that the patient will be in hospital for, and anything over and above that, they'll get paid the like a per day long stay payment. And usually that per day long stay payment is less than what you would be getting on the actual HRG itself, if you like. So, but of course, I did find an exception to the rule. But usually, if we take like EC14C, for example, if you divided like that 4888 divided by 14, I think it comes out something like 320 or something. So it's showing that per day you'd be getting more than the long stay, and that's to incentivize, in theory, you know, trying to free up the bed to make sure that you know, as many patients as we can as possible go through. So then we've got continuing on from the same thing. As I've said, we put in the primary diagnosis, we put in the procedures, and then we put in the comorbidities. So talking of comorbidities, if a patient, for example, has something, it's having a disease, you know, more than one disease or condition at a time, and obviously the more of these that a patient has, the more complicated things their care could be, in theory. So for example, if you've got a patient who has diabetes, they in theory could be harder to treat than a patient without diabetes. And so because of their comorbidities, that could increase the amount of money that a provider will receive for them. Then you've got interventions. I'll talk about intervention in a minute because it was something will come up in the wrong order. And laterality is about where, if the coding indicates where on the body that the treatment has been had, then often that can also lead to more money. And again, you've got things like if things are stated whether they're bilaterally, as in both sides, or unilaterally one side, then again, you get more money for bilateral. So going on to the interventions. So here's just an example of some interventions. And what we mean by interventions is, things that are happening during the patient's time in hospital. And although they might not be resource intensive enough to drive the HRG in their own right, they are still important enough to have some sort of money assigned to them, really. So in this case, the patient could be having something like, I don't know, plastic surgery, and then on top of that they've had a thigh lift. Well, of course, that still has taken some time and effort, and therefore the providers should be paid accordingly for that. So anyway, we put all this information in, which the trust do just by uploading their data into the grouper, a piece of software. And then on top of that, we have something called market forces factor, whereas, of course, if a provider is based in London, of course, they're going to get more money than a provider up north, because it's more expensive in theory to live in London, of course. But also you have things like the approach to an operation. I sort of couldn't quite fit that on my arrow. So, for example, if you have a hernia operation, you can do that a number of ways. You can do it laparoscopically, so keyhole surgery. You can do it open. You can do it robotic. You can do it ultrasound guided. All these different ways, in theory, could mean that the trust could end up with more money or less money, depending on which one they use, really. Right. So, but the point I'm trying to make is that providers don't just decide what HRG they want to assign to a patient. It's far more complicated than that. And if you ever try and ask a coder well, I'll give you an example. So I was working for a local hospital, and we found that so basically you get paid more for outpatient procedures. So if a procedure is done within an outpatient appointment, then of course it's going to take them longer than just the 5 minutes allotted time. And so in theory, they should get reimbursed for that. And what was happening was that in this hospital I was working in, they weren't getting reimbursed for their outpatient procedures, which is total madness, because we could be getting at least, I don't know, 2 times more money on top. So I attempted to revise to change the form, and I thought, oh, I know what I'll do. I'll work backwards. I'll go and speak to the coders and say, right, what they're doing these procedures, what do I need to capture here to enable us to get the right amount of money? And they wouldn't tell me. They wouldn't tell me, because they were saying, no, we'll be accused of gaming. We can't possibly help you. I mean, anyway. So yes, coders are they're great at what they do. They're very, very strict, and they can't be, they're very, they totally stay out of it, and they stick to the facts, which is great because we don't have this gaming issue. But anyway, let's carry on. So the value of recording comorbidities, I just did a data extract on the type of treatment that my daughter had. And as you can see, the 3 different types of HRGs that there are, the base HRG, which I'm thinking she fell into, was, her primary diagnosis, as I said, is the Q210. But had she had other issues, she would have the hospital would have ended up being paid more. So for the tier 1 HRG, you can see there are things like Q208, other congenital malformations of cardiac chambers and connections, or Z880, personal history of allergy to penicillin. So you can see there are more complications to these patients, and the more complications, the more money there ends up being attributed to them. And as you can see under tier 2, I mean, it just looks awful. So the Z884, for example, personal history of allergy to anaesthetic agent, that's going to be pretty difficult to manage, I imagine, if you're trying to do open heart surgery. So that's sort of justifying why the provider is getting much more money, because I'm sure they've had to come up with a workaround. I don't know. And in this case, I used the MFF of 17.1% because she had her surgery at the Royal Brompton, which is now Guy's, and that's the sort of MFF we're talking about. So there are two prices on each HRG, as you can see. The first one is the elective price, and the second one is the non-elective price. So just to give you an idea what a provider would end up of having a patient like my daughter in hospital. So when the coding goes wrong, this is a true example because my boss never stops telling me about it. You can't really believe it, but anyway. So yeah, sometimes, very rarely, the coding between the ICD-10 code and the OPCS code gets confused or mixed up. I don't know how it happens, but it does sometimes. So in this case, we had the dental treatment, OPCS code K028, other dental caries, which is basically a filling, and that groups to CB02, non-malignant ear, nose, mouth, throat, head or neck disorders. So this is what it should have coded to. When my boss was all those years ago, when she was doing her training, she was going through all the sort of exceptional items, things that looked a bit odd, and this one came up. So this is what it should have been coded to. But what it was coded to was this. So ICD-10 code K028, other specified, other transplantation of heart, which groups to ED05, standard heart transplant. So slightly different, but yeah, they got mixed up nonetheless. So she should have been charged, about 10 grand, and she was charged about 103,000. So yeah, a slight difference, but this is what can happen when the coding goes wrong. But as I say, it doesn't happen very often, but you understand the importance of it. So why is it important? Accurate clinical coding. Well, I've already talked about the, what is it in effect, like the financial flows and the basis of the finance. Commissioning obviously is very important, and I will cover that in the next couple of slides. So we'll come back to that. But firstly, so PQs, parliamentary questions. So we get in NHS England, we get a lot of parliamentary questions, and we should get at least 3 days to answer them, but we don't. We're lucky if we get a day. And obviously we have to trawl through all the data to find out what it is that they've asked us, and they can ask us goodness knows what. But anyway, that's something that is usually urgent for us, and it takes up quite a bit of our time now and then, but it ebbs and flows really. And then FOI is again very, very important, freedom of information requests, and these can come from anywhere, the public, media. We have a lot from the media, when they're doing documentaries and things like that. But the issue we find with both PQs and FOIs is that with specialised commissioning, we're only looking at often part of the pathway. We're not often looking at everything to do with that patient. We just specifically fund the particular part that links to specialised commissioning. And that can cause a bit of trouble because obviously we can only go back with that part, and then the person requesting the information still needs to get the other part, and that's often in other ICBs, which is difficult because it can be all over the place. But anyway, what else is why is it important? Well, we've got epidemiology studies, the study of how often diseases occur in different groups of people and why. So it helps us identify trends. Of course, that's important. We want to get that right, because if we don't know what the trend is, we don't know how to change our health services accordingly. And then we've got something called etiology, which is the study of causation of an illness or condition, and study the factors that come together to cause the illness. And again, outcome measurement, that's very important. We want to know that we're, what we're doing in the health service is the outcomes are good, and we need to measure everything, so we need it to be accurate. So just to quickly go through, so this is where commissioning comes in really. So currently I cost all the policies for specialised commissioning. So if let's say usually it's a clinician that's based in a hospital, and they see that either there's a new drug on the market in terms of, you know, something that's just become licensed, and in some cases, you know, it isn't licensed, and you know, but there's just starting, you know, emerging evidence to show that these things are working. But anyway, the clinician will decide that they want to either try, you know, have this drug brought in as a policy, or if there's a new procedure on the market, again, have that new procedure as part of a policy. So they would usually fill in something called a PPP, a preliminary policy proposition, and then that's submitted to NHS England. Everything's considered by the programme of care leads and the CRG generally, and clinical resource group, I think that stands for. And then they make the decision as to whether they think the policy would stand up and should go ahead. So at the point that this happens, they would then be putting together the policy proposition, you know, basically writing the policy, and then there'll be an integrated impact assessment alongside that, which highlights, you know, eligible numbers and what the current treatment is and what the new treatment is, and highlighting some important points really. So these two documents come to me per policy. I read them, and then I always have loads of questions. It's guaranteed, in which case I will meet with the commissioner and sometimes the clinician if it's really, really complicated, and then we'll go through how they want the policy to be modelled. So we tend to model things over 5 years. And then so I would then tend to, once I've met with them, run the data extracts and draft the finance model. And the way we look at it, or the way I look at it, is I have to consider what the current, so if this new treatment, so if the drug or the procedure tends to be, if that wasn't about, what would the cost of the current treatment be? So I have to cost that all up. So what are the current drugs, what is it, you know, how many outpatient appointments, how many, you know, is there any impact on emergencies, you name it, we have to think about it. And then we consider okay, so if this new treatment was to come in, how much would that cost us? And of course, if there's no change between, say, outpatient appointments, we just exclude anything where there's no change. It's only where there is a change, and by change, it has to be a, you know, a reasonably material change. It can't. There's no point in modelling things for like 50p here, and some of the, you know, some of the drug costs, you know, generic drug costs are very low in cost, so there's no point in including those. We're just talking about the main costs, really. Anyway, I draft my finance model. I often draft it about 3 or 4 times because my boss is very pernickety. And then once it's all perfect, I do all the, you know, she signs it off for me, and then I do all the paperwork. And obviously that picture there, the PMO picture, that is literally how much paper we have related to any one policy. It's a total nightmare. There's, you know, I think there's like 15 to 20 documents on one policy. I only have to do 4 of them, but that's quite enough, quite frankly. And it takes, you know, everything takes time, doesn't it? Every single document you have to complete. Anyway, so the point of all that is we get all the paperwork, and then we send it to a meeting called CPAG. So CPAG is the Clinical Policy Advisory Group. This meets on a monthly basis, but in terms of prioritisation, which is, you know, obviously we have a limited amount of resource. We tend to put 30 million aside per year for these types of treatments, SpecCom treatments, and we have to decide how we're going to spend that 30 million. So twice a year we have something called prioritisation, where usually about 9 policies will go to each prioritisation, and then, as it says there, complex decisions about what represents value for money for patients and taxpayers is considered. So my input obviously is doing you know, I work out the average cost per patient and the cost overall, and then they are ranked in relation to, you know, the relative cost per patient and the relative clinical benefit. And usually, you know, usually we can't afford, I'd say, you know, usually about 5 or 6 we end up coming below the line. And you know, the ones above the line, that we can't afford those, but they get 3 times to go to a CPAG prioritisation, and then it's we draw a line under it. It's not going to go. It's not going to be approved. But anyway, so that's and then I just thought I'd stick this in just so that if anyone wanted to read up on more policies, if they felt the need. You know, that we've got an example of, you know, all the SpecCom commission policies and service specs and policy statements. But basically, the underlying point is if we didn't have coding, there's no way I could do my job, because, you know, when it comes to me, you know, everything I cost, often I have to look at what is going on in the current data. You know, when I'm doing the current treatment, I need to understand what's going on on the ground currently to be able to cost it. So if that's all wrong, obviously it's going to affect my models, and then you're getting more things wrong, aren't you? Trying to when you're trying to get as accurate a cost. It's never going to be perfect, of course not, but you know, you're trying to do as accurate a cost as you can. And again, an example of the service spec there: pediatric congenital heart disease service spec. And a service spec, you know, we have a service spec for every service for SpecCom. Anyway, that's another story. That's it really. So thank you for listening. Are there any questions, or Becky, should I quickly show the Annex A and the codes group?
Why not? Yeah.
Yeah, is that all right?
Yeah, that's fine.
Right, I need to work out how to unshare. That's the only thing. Stop sharing. That might be a stop sharing. Right, hold on. Just gonna. Right, I'm just gonna put it on another screen just to be really. And I've got everything on another screen. Right, so. Sorry, everybody. Can you see that? Yeah.
Yeah.
So this is the COTA group, and there is a link in the presentation, obviously. So the main ones that I've covered, isn't it, about OPCS codes. So these are the procedure codes. So as you can see, there's loads of them. You can find everything on here, and basically I spend my life googling things, because they're not always, I'm sure to any clinician out there it's obvious what these procedures come under, but for somebody like me, I have to Google everything. And then same applies to the ICD-10 codes, really, the diagnosis codes. Again, you've got all the different codes there that you could ever want. And then, you know, the most complicated part really is working out what, you know, using the COTA group itself. And as I say, when you know what the HRG tends to be driven, as I've said, by the procedure code. So all I've put here is, this is my daughter having our open heart surgery. So I would put the code in, the K131, and it was a OPCS code, a procedure code. And then 2 come up. The top one is the one we want, that's elective, and the bottom one is non-elective or an emergency. So it's really that. And then you've got all different types here, which I could spend another day on explaining all the different types of codes and what it all means. But I won't bore you with that, you'll be pleased to know. So that's the COTA group. And then the Annex A is just once you know what HRG you have or you're talking about. So I think we were talking about EC14, weren't we? So this is literally all we do. They're all listed in here. So as I say, this is if it was an outpatient procedure, it would be coming up here. Day case, elective, non-elective. So that's all the admitted patient care. And then the outpatients, as I was mentioning, is slightly different. So we've got the first attendance and the follow-up. So these 4 HRGs here, but it's split by treatment function code. So depending on, whether you're going to a pain management service for your outpatients or spinal surgery service, you would have slightly different costs associated with each. And as I say, pediatric tends to be more, tend to get more money for those. And then, there's so much information in here, but, you've got unbundled prices. We've got a bit later on, best practice flags, but we have got the list of MFF in here, MFF values for all different providers if you really needed them. We've got list of drugs, and anyway, we could go on forever with all the different. We've got specialist flags in terms of, SpecCom often have top ups, but anyway, the main ones are the elective and non-elective that I've already mentioned. So I think that's it. Any questions, or is everyone asleep? It's difficult to
So
see,
is
isn't it?
Hi, I'm
There's a few in the
Sirisha. I
chat.
just have a quick question about the coding for 2 professional appointments that you mentioned earlier. What's the difference? And I get sometimes mixed up, and I would have done both ways, multidisciplinary and multi-professional. So if there are 2 consultants from different national stream of specialty and an allied health professional, does that come under multi-professional or multidisciplinary?
Not sure. Um,
And does
So don't-
tariff change, as in that 2, because you talked about coding for two clinicians, right? The number 2 was, I'm suspecting it's 2 clinicians in the same clinic.
yes, that's right.
So
It
why?
tends to be consultant led though. So I don't know if I mean, I don't know the ins and outs of all the detail, to be honest, at that level. I'm
Okay.
afraid. Sorry.
No worries. It's just that then why did they ask was my next question, but that's okay.
Okay. Sorry.
There's some more in the chat as well. I
Oh,
don't know if you can see.
Let's have a look. Oh. So do the codes and costing include non-medical treatments, physiotherapy, podiatry? Is this included in the comeback? So this is, I think this is all wrapped up as a rule in the HRGs themselves. So I think it's sort of like an overhead.
They can be coded separately. Fine, I'm okay. They can be coded separately. So physiotherapy, the MDT stuff can be coded separately and can be added on as a separate unbundled component.
Oh,
So I know that because we did it in our trust. So we managed to find a lot of opportunity because the physiotherapy, podiatry, dietetics, and stuff like that wasn't being coded. So yeah, they can be unbundled from the main. But it depends on the type of contract whether it actually makes a difference to the income, but they are coded differently.
right, okay. You can see that I don't often have things like physio, can't you? Because now that I'm speccom, I don't tend to, unfortunately, deal with that. That's good. What happens if a patient comes through A&E, has an operation, and then is readmitted? What HRGs would be used? So I take it to come through the non-elective route, but if it's readmitted, I think that's a separate spell, isn't it? Yeah. So yeah, it would be 2 separate HR. It's sort of treated separately in effect, unless of course I think they return within a certain period of time, in which case there might be a slight.
It still counts as a separate HRG. So you have 3 components. You have the A&E component, which is recorded on the emergency care data set, ECDS. Then you have the inpatient admission for the operation, and you have the readmission HRG as separately, because they can be on different consultants, so they end up as different episodes of care.
Right, lovely. Good job you're here to answer all the questions. I'm not sure about mental health. More and more focus on mental health.
So mental health is done on clusters. There was focus, so they tried to encourage people to. They tried to introduce tariff-based payments for mental health, but the accuracy of the clustering wasn't good enough. So because they're done by the clinicians rather than by, there's no coding team involved, so it's just on that. The main purpose of the tariff base was more to encourage the data quality improvements rather than to actually encourage activity-based payments. But most trusts are still paid on block or in a payment system. They never shifted to activity-based payments, and now they're back on the aligned and incentive payment scheme.
Okay. I'm not a coder, so I'm not sure about. I mean, I imagine it's done manually, but who's gonna be able to read those doctors' handwriting? I can't imagine a machine will be.
They're trying to do it, but the main problem is that how the data is entered. So increasingly with use of EPR, electronic patient records, they're trying to do machine-based coding using SNOMED coding. The main problem is most systems, the fields aren't defined enough. So you can't define a diagnosis code in a diagnosis field in most of these. It's the infrastructure behind the data entry on if you just type in free text, it's harder to get the machines to learn it. So it's still done manually for accuracy purposes. There is a time when coding will be done mostly by machines automatically, and then with the coding team checking rather than doing anything else.
One day. How does the coding tie in with the tariff that the trust receives, e.g. is it activity, and if coded incorrectly, the trust could receive too much or too little funding? Is it activity, and if coded incorrectly? Well, yeah, I mean, that's the issue. If you code things incorrectly or don't code things at all, like my example of the outpatient procedures, I mean, it was so infuriating as well, trying to change the process, and you had certain people not mentioning any names, clinicians not wanting to tick a box, and I was like, all you got to do is tick a box and then you get paid for it, so but yeah, it's key to try and get that it as accurately coded as possible. But there's going to be errors, or possibly overlooking things, especially with that right handwriting, I think that's all questions. Anything else? No, bored them all senseless.
Thank you, Coral. There you go.
Brilliant, thank you. Hello, everybody. My name's Jason Carrigan. I work for Midlands and Lancs Commissioning Support Unit, and we do work with primary care. We used to do actually practice accounts in Burnley, but then they got taken over by an acute trust. But we do a lot of PCN accounts and around the sort of area. So I don't know if you know anything about Midlands and Lancs CSU. We are a sort of support service that we do finance, HR, BI, back office services, and our sort of area runs right from Lancashire down to Hereford and across to Leicester. So that's what MLCSU do. Right, so I've been asked to do an introduction to funding and general practice. And it's just brief, and I know you've probably had a long day at this, so I'm going to try and keep it as brief as I can, and just go through some of the absolute basics of how GPs get funding, because it is really not simple. It comes in so many different tranches, and then eventually the partners take a cut of that, but we can discuss that at the end. Okay, next slide then, Becky, please. So, like you say, what we'll go through is what the core contract sort of deals with, and again, these are sort of funding streams really. So quality outcomes, quality and outcomes framework, QOF, enhanced services, premises funding, community-based services, primary care networks, which are getting bigger and bigger as the years go on, general practice IT, prescribing, NHE payments, and finally local authority payments. So like you say, a lot of different streams. It is not just a simple, it's not a simple sort of formula for general practice. It is a lot of different streams that kind of come in, and it obviously depends on how many different services that the actual GP practice might do as well. for that. Volume's erratic. I'll try and be as loud as I can. So next slide, please, Becky. So, like you say, in the core contract, the types of contract are the general medical services, and that's the main contract as such. So about 70% of general practice has a GMS contract, and that is the standard contract. One of the contract sort of holders must be a GP, and it's permanent. It's so it's a contract that sort of lasts in perpetuity until the practice either gives it up or it gets taken off them, which happens very rarely. So each general medical practice has a list size of its local population. That is obviously based on, well, so you have an actual list size, which the average is around 9,500 per practice, but it goes right down to literally 2,000 and right up to over 20,000 and even higher than that in some practices that have sort of acquired other practices as they've gone along. So, you know, there are some really big practices out there. The formula itself for the patients is done through a Carr-Hill weighted capitation. So, and that Carr-Hill weighted capitation is very much based on demographics. So things like elderly care, poorer areas, the practices in them areas get more money than they will in an area that has got a younger population and maybe more affluent. So that's how it's sort of based, really. So it's based on how much time that the GP will be spending with patients, and obviously you'll spend more time with the elderly and potentially the sort of poorer areas. The value per patient this year in the sort of core contract is £102 and 28 pence per patient. That's you know, so that's multiplied then by their list size on a weighted basis. So, you know, if it's 10,000 patients, it's at 102 times 10,000. There's quarterly list size adjustments. You can opt out of some core services, things like out of hours and childhood vaccinations and immunisations. We'll come on to that a bit at the end. There are other types of contracts as well, things like personal medical services, which are very similar to general medical contracts. They just add more services in. So there might be more nursing nurses in the practice to do more services in particular parts of the country. And you also get alternative provider of medical services contracts as well. And that's where maybe your private sort of your private companies come in, or your social enterprises can come in and take over a practice as well. But like you say, if you think general medical services are sort of 70% of it, PMS is probably a good over 20%, then APMS is it is the annual value per patient. Yes, there are other funding streams that come in as well, so it is that £102.28 per patient. Just answering that question. So next slide then, Becky. So as well as your core contract, you get paid for a quality and outcomes framework. So this is based on a points-based incentive scheme for GP practices. There are 635 points available, and the points range from a whole load of different domains. And where, you know, I've just put a few in there, things like flu vaccination, register of maintenance, like maintenance of long-term conditions, registers, prescribing indicators, early cancer diagnosis, things like, and then like you say, it's more care in terms of COPD, asthma, heart failure, mental health, etc. So it's paying the practices to do more work in certain areas because they are deemed. So there's 635 points available, and each QOF point is valued at £213.43. So if you've got an average list size of 9,374, which is similar to what we sort of took, is the, sort of the average list size, then it's that £213 times 635 is what you get for the that. Now, if your list size is less than that, then it's a sliding scale. So if you have 5,000 patients, you get less money because you have less patients to sort of look at. And if obviously you get more patients, then there's more as well. So again, that's another funding stream, another decent funding stream that comes through is QOF. Next slide, Becky. So then we can come to the other sort of enhanced services. So there are other sort of direct enhanced services, and these are usually contracted locally with the local ICB. And these cover things like minor surgeries, so things like some surgeries do lumps and bumps, joint injections, and these are usually paid per patient. So if you do more minor surgery, etc., then things. But there's other things as well, things like deregistered patients that have maybe been violent in other practices. If you take them on, you get more money for that. And then things like learning disability health checks. So again, it's just specific little bits of work that, like you say, I mean, can add up to quite a lot if you take quite a bit on. And certainly with minor surgeries, you can do quite a bit, and it's reasonably decent money if you can do that on a couple of sessions a week or something like that. Okay, next one, Becky. So in terms of their premises, so the practices actually own the premises. So in most cases, so everything that the practices spends on their premises gets funded. So things like rates, water rates, clinical waste, rent, so that gets paid, and then the rent sort of done down into, so it's either notional rent for properties owned by the partners, actual rent for properties that are leased, and then sort of health centre rent for properties that are owned by NHS Property Services. So they get refunded for everything that they spend in terms of the fabric of the building. Now, like you say, if they own the property, then at the end of if the practice or the partners own the property, then if they want to sell that property, they then get the profits of that. But this is the upkeep of it each year is paid for through the NHS. Okay, next one, Becky. So as well as sort of enhanced services, you get community-based services as well. So let's say these, again, locally commissioned services with ICBs. And again, this doesn't happen in every practice. It might only happen in a few practices in each area. But, there might be some areas where the practice might do minor injuries as well as, and that tends to be probably more rural areas. You've got near patient testing potentially as well, phlebotomy. Some practices will, deal with the traveling families that, so the practice, the families will be directed to certain practices. INR monitoring and breath testing, etc. So again, these are separate agreements, and they're either done by either price per activity or block arrangements. Again, these are only a small number of practices probably do this. and it's not big money, but it's another sort of funding stream that comes through. Okay, next slide. Now, something that's sort of come through in the last few years, really since July 2019, has been primary care networks, and this is something that's grown sort of massively in the last sort of 4 years, and will continue, or is looking like it's going to continue to grow. Primary care networks really is grouping GP practices together, usually in a specific geographical area. So, but it doesn't have to be that. It can be practices that are more friendly with each other, and they might not be as tight geographically. Serve typically a population between 30 and 50,000 patients. So, if you think your average list size per practice is something like 9,000, 9,500, you're talking maybe anything between 3 and 5 practices in each of the primary cares. They can be much bigger, but they don't tend to be a great deal smaller than 30,000. So, like you say, member practices receive a participation of £1.76 per weighted patient per year. So again, if it's another funding stream to practice to be part of a PCN. Now, to be part of PCNs, they're asking you to do quite a bit of work, and so a primary care network will receive support payments for clinical directors to cover. So that tends to be sort of a quarter of whole-time equivalent. So, sort of 2.5 sessions a week will be spent doing primary care network work for clinical directors. Core patient network payment of £1.50 per patient. So that's they have a core funding for each primary care network. Extended access, extended hours access is now changed to enhanced access. This is where practices do evening surgeries on top of their normal sort of 8 till 6 working day, so they'll do evenings and weekend surgeries, so they'll get paid for enhanced access to the extra sessions they do. One of the big elements as well is the impact and investment fund, and again, similar to the QOF funding, it's sort of indicator led, and it's asking practices and PCNs to do more work in certain categories, and show that they've done that, and that gets assessed each year. But there's funding that comes along with that. Like you say, potential 60 grand per PCN based on the success of improving access of that. There's leadership and management funding. So, like you say, each practice maybe has a practice manager helping, or they might cite I'm just trying to read that. Do GPs get paid the amount patient on their books? Yes. I'll come back to that question at the end. Workforce reimbursement. So the next slide has a whole list of new sort of additional roles that have come into general practice, and it's been massively successful. Something like an additional 40,000 new staff have gone into primary care. Now they've probably come from somewhere. The funding is massive. It's sort of £891 million in 23-24. That's something like an average of £750,000 for each primary care network. Will additional roles, and like you say, I'll come onto a list of that at the end. COVID vaccinations, obviously now most of the COVID vaccinations are done through GP practices. That's getting paid now at £12.58 per vaccination. And then there's other payments as well, such as winter capacity funding, which is another £250 million nationally, approximately 24,000 per PCN. And other capacity fundings and that depends on your individual ICBs. So like you say, all this money comes into the PCNs, and then there's a budget per, the budget for the PCN is done separately. But then at the end of the year, there might be some surplus monies in that budget, and that can get transferred down. Now that can be anything up to about another £20,000 a year for a practice in terms of surplus. Okay, Becky, for the next one, please. So this is the annual rolls reimbursement. These are the rolls that are there now. So these have been extended massively over the last sort of 18 months. So it first started with clinical pharmacists and pharmacy technicians, social prescribers and health and wellbeing coaches. They were the main sort of thing, and then it kind of very quickly went on to first contact physiotherapists, nurse training associates, advanced practitioners, and then like in the last sort of 12 months, you started getting things like dietitians and podiatrists and OTs and mental health as well, practitioners as well. So like you say, for an average sort of PCN now, you're taking on anything between another 20 to 30 staff this year, and that'll be paid for by a reimbursement service, and it's like you say, it's about £750,000 worth of reimbursement per PCN this year. So it's a not insignificant amount, and like you say, add that up with all the PCNs in the country, that's about another 40,000 staff that are new to primary care. They've obviously come from somewhere, whether that's from the acute sector or from the community or wherever, but it's new into primary care. As you can see there, you've got your maximum reimbursement amounts as well for that. So it can be that if your clinical pharmacist is top of the grade and is costs more than that, then you have to take that out of your core funding or other funding that's in there. So that applies to all the staff there. These are last year's rates, because obviously we've just sort of come through the new round of, so we'll get an updated one for 23-24 of the maximum reimbursement rates for 23-24. Okay, next slide, please. Right. So as well as all the other sort of funding streams that we've talked about, there are others as well. So other payments and support. So things like locum costs. So things like maternity care is reimbursed. So especially for GPs, sickness, it tends to be that the practice has to pay for the first 2 weeks of sickness, and then they get reimbursed in terms of locum costs. So it's not putting the practice at huge risk if two or three GPs go off on long-term sick. That money will come back into the practice through the commissioner. Reimbursement for things like syringes and needles, as you'd expect. GP information technology is obviously a huge sort of element of it, and it's only just come out as well that in the last day or two about telephony services. They want everyone to be on the same telephony services as each of is a standard telephony service, because they want to push sort of GP consultations more on the telephone. So all that, again, that sort of GP information, so all your servers, laptops, everything else that's in the practice is paid for. Prescribing fees and drug costs. There's also sort of NHS England commission schemes for immunisations and vaccinations. That's mainly sort of child immunisations, and support for trainee GPs as well. So some practices, like some trust, etc., will become trainee GP practices where students will go into. There are also other sort of public health services as well. So these when like local authority funded, so public health services, so like you say, contraception services, say IUCDs, smoking cessation services, and sort of drug misuse services as well. So again, other sort of forms of income for the practice. So like you say, it's not a simple sort of funding, you know, there's an awful lot of funding streams for general practice. If you're looking at what an average practice will get, so an average practice of something like 10,000 patients will get in excess, and it depends again how many services you run and how many don't run, but an average practice will probably get something like £1.5 million, and that's, you know, that's mainly to pay staff, because obviously most of your costs that are your direct costs are covered in here. And another thing that sort of was made clear over the last couple of years was insurance as well. So GPs used to have to take out their own sort of private medical insurance, but now that's been done separately as well, and that's all part of the NHS scheme as well. So that's part of their payment as well. So that's really everything. So it's very, very complex, and GPs and practice managers have their work cut out to yeah, it is amazing how much the government has put, how much investment has gone into GP practices over the last few years. It's you know, it huge amount of money, especially like you say around the Rs and the PCNs. That's the way they're trying to push new services being introduced, is through primary care networks and these sort of new additional roles that are going into GPs. And I think the idea is there's supposed to be, I think I read the other day, there's supposed to be 5,000 new GPs since 2019. There's actually I've heard 862 less GPs than there were in 2019 now. So all these additional roles, whether it's mental health or physios and that sort of stuff, are doing some of the work that the GPs probably would have done, you know, 4 or 5 years ago. Right, that's, I think, the whole of the presentation. For some reason, hold on, let me just have a look. So any questions? Let me just have a look at the questions you've got. Actually, so the last question was hugely complex. How confident in general are GP? They're usually pretty confident. So it's practice managers tend to come from within the, you know, within the general practice. So they might have been admin staff before and stuff like that. So they know the system, they know where the funding comes from. It is hugely sort of complex, and the GPs are masters at it. They, you know, they're private enterprises basically. They are, you know, they are businesses, so they know their, you know, certainly the partners know their business, and they know where the money's coming from, and they're very involved in that. And the practice will meet probably, if not weekly, or definitely monthly, and they'll go through budgets, and it's, you know, the GPs are very involved in that. So it is they, you know, they are very confident in what they do. Sorry, just going on to Jayshree's, I kind of saw half of it when I was presenting, but why is this not, you said, why is that not mirrored in the secondary sector? Honestly, I couldn't tell you. You know, that's been the direction of, I suppose there's always been that case where they say if you get general practice right, then it kind of stops more things being pushed into the secondary sector. I don't know if that's happened or not. Obviously, having 5,000 less GPs doesn't help from what they had in 2019, but that's or less GPs than they had. Maybe that's why it's right. So the last question again from J Street is, what are the average costs after all the reimbursements? So just to give you an idea, so GPs will make a profit, and how much they make of that profit is, and this is only the practices that I've had to deal with, they've been making anywhere between £100,000 and £120,000 worth of profit a year, and they'll take that out the business. Now there might be 2-3 partners in the business that take that out, but that's only if it's there. So as funding streams, and inflation, pay inflation, and all that sort of stuff get higher, then that might squeeze into that sort of profit area. When I say that's sort of the element of that's how much they make, that probably was 3 or 4 years ago. Again, that might have been squeezed over the last few years. TT, the PCN leadership and management funds, are these for the individual practice or the PCN managerial team? The PCN leadership and management funds are specifically for the PCNs. So like you say, each practice is part of that sort of partnership in terms of the PCN. So it could be that some of that helps with some of the practice sort of leadership and management, but it is specifically for the PCN, that PCN sort of leadership and management funds. What percentage of the annual NHS budget goes to funding? It's ridiculously low. I wish I had the numbers. It's something like 10% of the annual NHS budget goes to primary care, and I think that's it's a very small percentage that goes to primary care. Obviously, if you speak to primary care, they want a bigger element of that. But it's a very small element of it. Any other questions, anybody? I know you've had a long day. You're right. The profit is essentially the partner's salary. You're right. That's absolutely right. Any other questions? Well, I hope it's just sort of shown you how complex general practice is in terms of its funding streams, and some of the work that they need to get into to bolster their sort of to bolster their income. Like you say, I think right. So again, there's probably different elements to GP. So there are some GPs that are salary GPs, and there are some GPs that are partners. So if you might have a really big practice which has 15,000 patients, you might have 6 or 7 GPs in that practice, maybe more. It might be that 2 or 3 of them GPs are salary GPs, and they'll be on £90,000 a year, and then the partners themselves will, as we said before, will take the profits out of the business, and that's their salary. And other questions? Oh, J3, what a great question, and I'm sure every so J3's asked, why don't they simplify the funding streams and do block contracts? Great question. I think one of the issues with that is, I think, because at the moment DMS and the partnership model that they've got in general practice is, they are private entities. I think once you start going into more block contracts and that sort of elements, then are you taking that sort of private enterprise out of the GP, the GP? So that might be an element of it. it would make much more sense to do things on a more block contract basis and sort of say, okay, well, you've got 15, you've got 10,000 patients, we're going to give you this. That would make much more sense, but that's not historically the way it's done. And I think the way it's done is is that sort of partnership model and that sort of private enterprise sort of element of general practice. I think the questions seem to have slowed up a bit, Becky, if you
That's great. Thank you so much. That was really informative. I will stop spotlighting you, and next we are on to Kirsty Petty, Alex Dakin, Adam Lacker for understanding budgets and spreadsheets. I think they're all here.
Thank you, everybody.
Yeah. Thank you, Jason.
Thank you.
Hello. Yes, we're all here. Am I sharing my slides or are you bringing them up?
You're talking to me.
Yes.
You can
I'll
share
share
them if
mine.
you like, if it's
Okay.
easier, whatever's easiest.
That's fine. I'm ready just in case. Okay. So yeah, I'm Kirsty Petty. I'm one of the senior finance managers at ELHT, and myself, along with my colleagues Alex and Adam, have some slides to share today around understanding budgets. So I thought before we dive into that, I'd just share a little bit about ELHT. So East Lancashire Hospitals NHS Trust provide a high quality acute secondary healthcare and more recently primary care for the people of East Lancashire and Blackburn with Darwen. So we employ just over 8,000 staff and treat just over 700,000 patients a year across 5 hospital sites and various community sites. We have a total of 1,041 beds, and we do this with an annual income of just over 700 million. We do actually at ELHT also provide a wide range of services at ELHT, such as head and neck and neurological cancer specialist services. So the finance department teams. So at ELHT, we have the financial management team, which is also known as the management accounts team in other organisations. And this team focuses on providing the information that the trust needs to understand its cost base and its drivers on its income and expenditure. So they look at waste reduction programmes, budget setting, variance analysis, forecasting, etc. But we'll dive into that a little bit later on another slide. We also have the income and costing team, so they focus on aspects of income such as and reporting on SLAM monitoring, contracting. They'll lead on all the contract negotiations with commissioners for the trust. They'll also oversee the costing and efficiency reporting, and that will include the PLIX team, the patient level information costing team. And then we have our financial accounts team. So this team leads on the financial controls and cash management for revenue and capital income and expenditure. So they will focus on cash and liquidity and the key statutory duties of the trust. And what you may see in other organisations in-house is other teams such as the payroll team, accounts receivable, accounts payable, but ELHT, like many other organisations, outsource that. So I just thought I'd mention a little bit on the finance values at ELHT. So they're very much aligned with the FFF Future Focused Finance strengths, and they're very much embedded into our finance culture. So we put patients first, we respect the individual, we act with integrity, serve the community and promote positive change. And we actually also have an employee of the month each month at ELHT, and we actually embed the 4 strengths into those nominations. So we always look at to say, well, how has this person been a finance expert? Have they been a team player? How have they driven value for patients and taxpayers? And how have they made change happen? So it's very much part of our culture. So we'll get stuck into it now. So what is a budget and how does it all work? And I will pass you over to Alex.
Hi, I'm Alex Dakin. I'm one of the divisional finance managers at ELHT. So what is a budget? So of course, it is a plan of what you intend to do in each period expressed in financial terms. Now, of course, it's not always just financial terms. You may well have activity budgets as well as a financial budget. The period can be daily, monthly or annually. And of course, we all budget now in our personal lives through salary. You may have rent or mortgage to pay. You've got kids to pay for. So budgeting is very much kind of intertwined with our daily lives. So of course, within a budget, you look at how much you're going to spend on your staffing requirement, as well as any non-pay consumables, contracts for say maintenance of equipment. Drugs is a massive non-pay spend in the NHS, as well as our liability insurance, better known as CNST. We also need to take into account kind of our manpower considerations. So we all have safer staffing reviews on wards. You've also got professional judgment that we undertake annually. And as well as that, kind of as part of your safer staffing reviews that we do have huddles for daily, you may well see that you've got gaps that you have to cover with bank or agency, which again would go against your budget, and you have to manage that effectively. Again, not as I mentioned before, it's not just about the financial envelope. You may well have activity budget as well, especially if it's an outpatient or elective service, which again has its own caveats and pressures associated with it, especially on how much income you think you may be getting for that year and what resource you'll have available to achieve that level. So why do we need a budget in the first place? So the NHS, like all other organisations and businesses, has a limited pool of resources, and we must manage taxpayers' money as efficiently as possible. So again, a budget is a critical part of organisational planning. This is so the trust can identify its expenditure against its expected income for the forthcoming year, and then put mitigations into place if we are seeing potential overspends in the future because of price rises, which again, over the last 12 months, we have seen a significant number of price increases across different consumables and non-pay. It is also a control for our expenditure, again, to ensure that the trust and the taxpayers receive value for money. For authorisation, again, which is another control measure, so a budget holder will ensure costs incurred are valid by authorising those costs on the budget, and anything out of the ordinary should again be queried with the finance team or financial services. And performance and accountability. So budgets again are critical to organisational success. It gives us a metric and a means to put plans in place to mitigate any future risks that we may see developing as the months go on, especially as we go towards winter, which is always a very difficult time for the NHS. So just as a really quick example, I'll just put a brief kind of flow chart together on how we set our budget in our organisation. So again, the contracting round for 23-24 has been simplified, again in line with 22-23, but this time it's only to an extent. So the trust does remain on block contracts for non-elective elements of income, but outpatient and electives are back to cost per case for this financial year. Other streams are also looked at, so we look at our education funding and how many funded education places that we have. Overseas visitors, which again varies by trust to trust and month on month as well as research and development, to again see how much income we've got available through different grants and funding. For pay, so all established staffing posts, so staff where you have budget for them, are recosted each year to again take into account pay award, incremental changes, as well as any changes again as we've seen over the last 12 months with changes to national insurance, which has again been removed as of a couple of months ago. And this year, as part of the planning guidance, we added 2.1% on top of our pay budget for pay award. We also take account of any foreseen pressures and service developments. These are collated by divisional finance managers for review by the Deputy Director and Director of Finance. Non-pay inflation for this financial year has been funded at 4% apart from drugs, which was funded at 1.3%. The cost of the trust liability insurance, or CNST, is received, and then our WRP percentage is calculated. Now, WRP is a very, it's basically your CIP or cost improvement program. I'm aware that just each trust calls it something a little different, so just thought I'd put that context there. So can a budget be changed in the year? Ordinarily, no. So, of course, when we come to our planning round, we submit a financial position or a financial plan to NHS England to say this is what we expect to outturn come the year end, and then they can either agree it or put any challenge in, and then there's some toing and froing until we come to an agreement of where we should be falling by the year end. So again, because of that, NHSE always want to monitor our performance month on month versus that plan. So we shouldn't really be making any changes to our bottom line position. But again, some organisations do change in line with local service plans, which again can be without changing the trust bottom line. So it may well be that you've got a new service coming on, which is income funded by staffing, and of course you've got your non-paying your overheads, or it may well be that you lost a service and that is all to pay into another organisation. So again, just on that occasions where something sizable does happen mid-year, and that does warrant that change in the budget. So we're on budgets. We don't just have revenue budgets or a budget. The budget is split between capital and revenue. So for last year, the capital budget was just short of £8 billion. This is for all equipment, building work, anything that is expected to last for over a year, and a single item has to cost over £5,000 for it to be classed as capital expenditure. Trusts are set a capital resource limit by NHS England, and again, we can't exceed that without permission, or it may well be that we have some additional grants that we receive through central funds to do additional work. And as well as capital, we also have revenue. So revenue is significantly bigger than our capital budget at around £153 billion. This is again for all our day-to-day running costs of salaries, drugs, non-pay, any consumables, and that relates to a period of time of less than 1 year. So all in all, the budget is around £160 billion. So now that we know about budgets, I'm going to pass on to Adam, who will give a little bit of detail on how we manage them.
Thank you very much. My name is Adam, and I'm the income analyst. And up until recently, I was part of the financial management team. So what is financial management? So it is when we plan and monitor budgets, supporting accurate and effective financial reporting, and supporting the delivery of the forecast outturn, supporting the achievement of the NHS cost improvement programme, or as Alex said, the waste reduction programme, robust and effective costing and service developments. So there should be regular budget meetings set up between the divisional finance teams and service managers to ensure that budgets are planned and monitored effectively. This team should be embedded within the services in order to understand them and the numbers, and to add context to the financial position. The financial management team should be involved in any service developments from the outset to ensure that accurate costings are provided at the earliest opportunity. So what are the responsibilities of budget holders? So it is to ensure that they engage with the finance team. So this is meeting with divisional finance teams regularly. So in our trust, we meet with our budget holders on a month-to-month basis. We ensure accurate budgets. So ensuring any budget effective changes or info is passed on to the finance team at the earliest opportunity, so that these changes can be made before the next budget statements are sent out, and so that the budget holders can see the changes made on their statements at the earliest possible opportunity for them, and manage budgets in line with SFIs, and then also to reach out and ask for support. So this is through regular budget meetings, ad hoc requests to the finance teams through emails, or over the phone, over Teams, etc., and also manage and contribute to the NHS cost improvement programme. So what is the NHS Cost Improvement Programme? So there are two ways to increase value for service users. So this is to improve outcomes without compromising cost, and to reduce cost without compromising the outcomes. So to do this, we have to increase efficiency and reduce expenditure. And it can be done by year on year or also one-off savings. In 2023 and 24, we have a £5.6 billion pound efficiency plan, which is equivalent to 5% of the turnover. The efficiency plan in 22-23, we delivered £2.9 billion, which is half of what the plan is for 23-24. So it is a very tough target for 23-24, given the achievement in 22-23. It is important to share any cost-saving efficiency ideas with the finance team, so these can be costed up and discussed in more detail. The Carter Review identified £5 billion in efficiency savings in acute trusts by 2020. The Quality Improvement Programme Challenge is an opportunity for high quality care in a tight economic climate. I will pass it on to Kirsty to finish off.
Yeah. So what does the future hold for the ELHT and the NHS? So there's increasing financial security, and that's due to many factors. So we have the increasing cost of the NHS, and that's driven further by the cost of living crisis and the 40-year high of inflation. There's evolving healthcare needs, and we've got higher levels of acuity and dependency, and this is fueled by not only the pandemic, but an aging and growing population as well. We're still coming out of the pandemic, and we still are recovering with our activity on that as well. And that's along with workforce shortages, bed shortages, long waiting lists, the growth of digital technology and political changes. So of course, when we have a change in government, that means the change to the NHS is inevitable. So all these challenges are always there. So what kind of things can we do to help manage those pressures in the NHS? So we can look at changing the healthcare landscape. So for example, we've seen the creation of ICBs, more trusts that are merging. So in Manchester, for example, they now are governed by just one single acute trust. Collaboration is obviously going to be really big. So we've got to provide a collaborative that are forming as well across the NHS. So that'll be about standardising practice, working together, getting the best practice. And it also means using the model hospital more, standardising and pulling on the best practice for that, and joint access across a wider patch for our patients, really. So that kind of concludes our whistle-top tour of understanding budgets. We hope you found it useful. Thanks for inviting us. And we welcome any questions either now, or we're happy to do a one-to-one if anyone needs to or wants to know any more. Thank you. Questions? Okay. Thank you for your time.
Thank you.
You've got a question come in the chat.
Yeah, so the difference between recurrent and non-recurrent CIP. So of course, your non-recurrent, it's a one-off, so it may well be that you've negated a contract, for example. You may have some slippage in your staffing. So if you've got a new service set up, potentially it's funding 10 staff, because of course the difficult landscape that we find ourselves in with recruiting staff at the moment, it may well be that you go 6 months with say only having half of that workforce. You could then potentially say that that is a small saving, because of course you've not spent that entire allocation of money between in that financial year. And of course recurrent, so just an example from our trust, we have a very large Medtronic contract, and a lot of work was done between corporate colleagues and solicitors around looking at the contract and looking at how we can kind of reword the contract to enable us to reclaim the VAT, and that led to a £500,000 annual saving. So a recurrent saving is a saving you're going to make year on year, continuously, kind of forever. So just Claire, just on your point, it's very difficult. We have to go off the guidance that we receive from NHS England. So in this case, they gave us a 2.1% pay award to add on top, just for planning purposes. And of course, if that figure was to change, which it has done, then additional funding will come across to cover that. I think that's everything that I can see.
Cool. Thank you so much. That was really good.
Thank you.
Thank you.
Thanks. And we've got a few minutes left, so I can just give you all that time back. Thank you so much for attending. I hope you enjoyed it.
Thank you.